versus capecitabine for 6 cycles. At the fifth interim analysis, the hazard ratio for platinum versus capecitabine was 1.09, and that did not show any benefit, or that did not show any superiority or non-inferiority of platinum over capecitabine. Grade 3 and 4 toxicities were also more common with the platinum agents, and the Data Safety Monitoring Committee recommended stopping the trial because it was unlikely that any further follow-up would show either non-inferiority or superiority. The 3-year invasive disease-free survival for platinum was 42% versus 49% for capecitabine in the basal type, whereas this was 46% versus 69% in the non-basal type of triple-negative breast cancer. What's good about this study is the design. It's a hybrid design, which is quite, its superiority as well as non-inferiority, so that's quite elegant. The reporting is honest, and they have done really meticulous analysis at each interim, where the fifth interim has proved the futility of further continuation of study. However, the authors themselves have said that there are certain shortcomings, especially they could not explain why why was the outcome so poor when they started off with an expectation of 67% invasive disease-free survival in the capecitabine arm. But what we actually saw was nearly 40-50% survival. This could be explained by certain facts like they actually included patients who had a higher residual disease. There were lesser number of, and it also could be a bit with the to do with the methodology, because the study received criticism why only 4 cycles of platinum were used instead of 6, and there was also a long gap between actually finishing all the adjuvant and starting the maintenance treatment, with the median of this gap being 4 months, which is really quite long. And what also I could not find anywhere in the paper is it is not clear how many patients have actually received platinum agents in the neoadjuvant chemotherapy. So capecitabine would still remain the standard of care in patients who do not achieve PCR in triple-negative breast cancer patients as a maintenance treatment. However, additional ongoing trials may throw some more light before we refute the role of platinum in the maintenance setting. The PALAS study that got published in February 2021 looked at continuing endocrine, adding a CDK4/6 inhibitor like palbociclib in the adjuvant endocrine therapy regimen in early breast cancer patients. So this was an open-label randomized phase 3 study of addition of 2 years of palbociclib in stage 2 and 3 breast cancer. The sample size calculation was done based on a hazard ratio of 0.75 and aiming to show an absolute benefit of 2.5%. A 3-year invasive disease-free survival was 88.2% for palbociclib plus endocrine therapy patients and 88.5% for endocrine therapy alone patients. So the study failed to meet its primary endpoint. As 67% events happened at the second interim analysis, the futility boundary was crossed and the study was stopped prematurely. 60% patients had grade 3 to 4 neutropenia due to palbociclib, and that led to a 40% early discontinuation. Although the plan was to give palbociclib for 2 years, the actual medial duration of palbociclib received by patients was only 18 months, and at more than 50% patients needed at least 1 dose reduction at 2 years. This also the benefit was not seen across any subgroups. There was no subgroup that actually benefited from the use of palbociclib. So therapy successful in the metastatic setting need not be so in the adjuvant setting, and we may need to really wait for further data with other CDK4/6 inhibitors like ribociclib, which have shown some promise in their early results. The updated results of the Affinity trial were published earlier this year, and it did show an overall invasive disease-free survival benefit of 2.8% in all the patients, where the outcome was improved from 87.8 to 90.6% whenever pertuzumab was used along with trastuzumab in the adjuvant setting in HER2-positive breast cancer patients. However, there was no overall survival benefit. Also, a majority of this benefit comes from treatment of patients who are node positive, where a 4.5% benefit was seen, and there was 0.1% benefit in the node negative patients. The benefit comes with a incremental cost of 40 lakh Indian rupees as of now, and
For the FAIRY, we've got the Persephone and we've got the POP trial. We've got 9 weeks duration with the SHORTHER, the FINHER, and the SOUL trial. And of course, we're not going to be discussing it, but we've got the trials that establish the standard of care, the NACBP 31, the BCIRG 006, which we will not be discussing today. And also we've got trials that put, that 1 year as a standard of therapy and not 2 years, that is the HERA trial. So as of now, in our clinical practice, trastuzumab for 1 year is the standard of care for early breast cancer as recommended by the guidelines. So far we've got strong HERA data, good follow-up data. FINHER showed us that 9 weeks is better than nothing, but the updated results did not favor 9 weeks of therapy. And we've got a bunch of non-inferiority trials for 6 months versus 1 year, and some of them failed to prove until recently, and I'll come to that in the later slides. So this lady with a high risk of relapse, you would always prefer to do a 1 year, and that looks like a reasonable option. So let us look at the data one by one. So this is the data of FINHER, which did not show statistically significant improvement in the distant disease survival or the overall survival. You can see with 1 year versus 9 weeks of therapy, and you can see the curves are separating, both in terms of distant disease-free survival and the overall survival. Next, looking at the SHORTHER trial. So this is, you can see that the disease-free survival, you can look at it. It's about 5 years, 87.5% for the long infusion, and the short 9 weeks is 85.4%. And the issue with SHORTHER is that the trial did not meet its primary endpoint of showing 9 weeks of trastuzumab being non-inferior to 1 year of therapy. And after median follow-up of about 5.2 years, the DFS was actually inferior in the 9 weeks of therapy. But when they looked at the toxicity, the rate of toxicity was nearly half with a shorter duration of therapy. So they established a standard of 1 year of trastuzumab and it supported the data. However, what SHORTHER did identify is that there were 3 different prognostic groups: the low risk, intermediate, and the high risk. And they defined it based on the size of the tumor and the nodal disease. Anybody less than 2 centimeters with N0 disease was a low risk, which was accounting for about 37% of the patients. Intermediate was less than 2 centimeter of size with any N category, which was a majority of the patients, about 50%. And high risk was more than 2 centimeters with N4 disease, accounting for about 10.5% of the patients. So what they really found is that 1 year of treatment was better if you had a high risk population, that is multiple positive nodes or a stage 3 disease. And 9 weeks of therapy, you wouldn't rubbish it and throw it in the dustbin, but you would actually utilize this 9 weeks of therapy for a low burden population, like say stage 1, stage 2, and a limited nodal burden disease. So it still has its place. However, you have to choose your population in the right way. So next, coming to the FAIRY trial, which is the 6 months versus the 12 months of adjuvant trastuzumab in HER-positive breast cancer. And this, again, it show that when they looked and compared both subgroups in terms of local recurrence, regional recurrence, and distal recurrences, they were definitely much lower in the trastuzumab 12 months duration population as opposed to those who received it for 6 months. And also, when they looked into the subgroup analysis of ER positive versus ER negative, and then the sequential therapy versus concurrent therapy, what they found is that the ER negative sequential therapy population, this was probably the population who did the best and had the best DFS benefit with a 1 year treatment as opposed to a 6 month treatment. So this is probably your population where you have to use a 1 year treatment. However, overall, the trial failed to show 6 months of therapy of adjuvant trastuzumab being non-inferior to 12 months. And they showed that the standard of care should remain as 12 months of adjuvant trastuzumab. However, what was the positive aspects of the study? It managed to show that if you had an under-resourced population, you may actually benefit with 6 months of trastuzumab because it's not that they do that bad. So you can still consider it in your population and individualize it based on the risk factors of the patient. So which were the subset of population that did poorly in the FAIR trial? It was actually the ones who had a higher nodal burden. This is where the difference was 90.4% at the end of 12 months. This is a 3-year DFS, as opposed to 78.4% in patients who had 3 nodes, more than 3 nodes. So this is the population that you need to target with a longer duration of therapy. And we come to the Persephone trial, which is actually a positive trial. And this was the positive trial that showed that The 6 months is non-inferior to the 12-month therapy, and this is the 4-year disease-free data.
Thank you, Dr. Suman, for a very interesting presentation. I think we've just reached the right time, 5 p.m., which was allotted to this session. May I request Dr. Chintamani and Dr. Ramesh Sareen to make one or two important comments or questions and then wind up.
Thank you very much. Wonderful, very educative, and the last one especially. I think they've dissected it beautifully, but to start with, I think Shalaga really run through it, and she brought out very, very important points, including, I'll quickly touch the BCS being superior to mastectomy, that the Swedish trial from JAMA. And she was very right in pointing out the equivalence is already known, but superiority, we still need to be working. And there were some issues with the trial, but as of now, we all offer it to the patient that breast conservation surgery is not just equal to mastectomy, it's superior. And there are many hypotheses for that. One is the immune response of the patient, and people feel that the more trauma done, the worse outcome. So there are many, many hypotheses, but definitely there was some aspect that she covered. So there's no point repeating it, and it's very nicely covered. Similarly, about the de-escalation for for me, the important trials that she discussed, the axillary surgery, and she brought out very nicely. It is still, as of now, there is a challenge when we are not accepting Z11 also as something that you can replicate. Just taking, the one odd study here and there, and micrometastasis, single micrometastasis being in the sentinel node. I mean, it still needs to be looked at carefully. And as she rightly mentioned, the cones were just short study and non-randomized. Although it's very difficult to randomize these studies, and I think we've been chasing randomized RCTs for too long. There are occasions when you may not be able to do it. I think by and large, everything was covered beautifully, including the margin post NSCT. And I agree with her. When we accept it in the upfront scenario, we should be able to accept it. Although that comes more out of the background or the fear that maybe you'll be missing out some disease. But another very interesting trial. And I think the most important one is the one that's come from Tata on the screening, and that I think will need to be studied. But surprisingly, and also as rightly brought out by her, it'll have its challenges. One is it's not working. It's not able to make an impact in less than 50 years, and that's where we get most of our cancers these days, the younger women. And the clinical breast examination was more for this group that we were looking at, but something that is coming out of a large pool of data. The rest was more or less covered. The metastatic breast cancer meta-analysis continues to be controversial. We basically are cherry picking. It's very difficult to make out which trial had which advantage. Naturally, there were some problems with each one of them. As of now, there is no evidence to suggest that it's beneficial. And in fact, we just got to make sure that it doesn't hurt. And there are trials to show that probably will worsen the outcome, except for the situation when there's bleeding or there's a local issue. I think by and large, otherwise, I won't be touching the parts that were covered by Dr. Arya and Dr. Suman. They were beautifully analyzed. Olap, when we talk about these studies and when we actually look at them, they're all non-inferiority studies. So at best, they're as good and they're not superior. So when we're looking at the cost, when looking at the toxicity, and I think olaparib is it's a huge amount of hematological toxicity besides the cost. It's not something that one can very easily accept, although it's an interim analysis, that the quality of life didn't actually go down. But that's what the study is about. But it works very well for a particular group. And so coming to the last part, which was very nicely covered, I think there's nothing much that I'll have to say. Everything was very, very nicely elaborated. I'll leave that to Dr. Sareen to analyze further. Thank you.
Hello. Hi, good evening. I just had to go on my mobile phone. I do not know what's wrong with my computer audio. Anyway, I'll just say whatever I could get in one line, each trial. The first one where we said that in mastectomy group, if you have a micromet, you could leave it and not even give them radiation. If they don't require radiation, the overall survival is the same. I would say, I think Vedant said that 8 years ago when we had the Z0011 trial, that if on a paraffin section, the sentinel node comes as micromet after a negative frozen section, don't go back and dissect the axilla. So I think that still holds true. And in a good prognostic tumor, even if you get a micromet, and you must know what is a micromet, you need not dissect the axilla if it's a good biology of HER2 positive. The second one, I am not sure about the width margin of less than 2 versus more than 2 in patients having BCS after neoadjuvant chemotherapy. Our patients are different, our circumstances are different, our socioeconomic and follow-up is different. So I am not too happy if we try to do smaller excisions with less than 2 centimeter margin. So I would try and still do more than 5 cm, 5.5 cm margin. But if one margin out of the 5 or 6 comes as less than 2, you can think of not going back and excising it. But I try and would do more than 5 millimeter margin, because our patients do not come for follow-up, do not come for MRI. The tumors are larger and the response may not be multicentric, and there is a skip metastasis. So I am not yet confident of having less than 2 millimeter margins all around. The Indian study is just excellent study, large study, a lot of hard work, but I think though we didn't overdiagnose, but we don't really know if we underdiagnosed. And at least the one good thing about it is that people were made aware of how to look at their breast, what are the early signs of breast cancer, and that if they have it, they should come. So I think it must have benefited a whole lot of people. Breast surgery in the face of metastatic study, I think it's quite well that if a patient is responding distantly very well and also responding to the local breast tumor, there is no need to do a mastectomy. Only if the local disease is not responding, you may add on to the mastectomy. But as a general rule, it's not really the first line and should be kept in the last line at the back of your mind. Capecitabine versus platinum. I think lots and lots of people, at least in India, are now giving neoadjuvant chemotherapy with capecitabine. And so the study still we don't know. There are trials going on by adding cisplatinum, carboplatin cisplatinum in triple negative and in BRCA positive patients. Pertuzumab affinity trial, difficult to exhibit. The adjuvant study is showing very little benefit of 2% only, but the neoadjuvant is showing a 15% benefit. Now, if we take neoadjuvant chemotherapy PCR as a surrogate marker, I don't understand why the adjuvant is not working. So I'm actually very confused. If we do consider PCR as a surrogate marker and as a strong surrogate marker, if you see the ADAPT trial, this is the surrogate marker, the PCR. And so if PCR is PCR after neoadjuvant with the pertuzumab is showing 15%, the adjuvant is showing 2%. So it's difficult for me to understand why adjuvant is not showing benefit. Now, I'll just come 1 minute only to the Olympia trial. I think it's an excellent trial. They had done studies in the metastatic disease and had shown an improvement. And this is an excellent trial in 1,800 odd patients, randomized phase 3 studies. 1 year of olaparib, 7.1% absolute benefit. I think this is the same benefit as we had when we had the Herceptin being presented, the Herceptin study. So, and the side effects are very little. The only thing I have not been able to grasp, and if Devvrat can elaborate, did they give the hormonal treatment and olaparib concurrently in HER2 positive patients? Now, if we are going to delay hormonal treatment for 1 year in trying to give olaparib, I do not know the benefit. And can we add olaparib and hormonal treatment in patients who are HIV positive? I know lots of patients were HER2 negative, I mean triple negative, but there were a few patients who were hormone receptor positive. Now, I won't discuss about the DAP study, but it was an excellent study. I think that's what we need today. But coming to the 6 months to 1 year, I've heard that for the last 4 years, and every time 3 good studies, one from England and the other 2 studies, the FAIR study and this, they all are showing non-inferiority to 6 months. But at the end of the conclusion, they say 1 year is the standard of treatment. So I think, to my mind, if somebody cannot afford it, you don't let them feel guilty about it and give them 6 months of Herceptin as against 1 year. And today, as I see in our practice and everybody's practice, the cost of Herceptin has gone down to 18,000 rupees versus 1,18,000. So most people afford 1 year. So if they want to take it 1 year because mentally they want to feel that they've done all the best possible, then let it be 1 year. But if somebody, a driver or somebody cannot take Herceptin, don't push for 1 year. 6 months is as good as 1 year, especially in early breast cancer disease. Yes, obviously, if there are 4 lymph nodes and more than 4 lymph nodes involved, push for 1 year. But in early breast cancer disease, if somebody really can't afford it, just 6 months without being guilty about it should be advocated.
Thank you.
And
Thank you so much.
Vedant, that's it from my side. I hope it made some sense. Thank you for having me.
Thank you, Dr. Sareen. Thank you, Dr. Chintamani. And thank you all the speakers for a wonderful session. And I think we had a wonderful first session of the meeting today. And with this, we close down our breast session. And I invite Dr. Rama Joshi. Dr. Rama Joshi is a senior director and gynae surgical oncologist at Fortis Hospital, Gurgaon. Dr. Joshi, you may start the gynae session now.
Welcome you all to the interesting session that is the gynec oncology session. In this, we have got 2 sessions, and I invite the chairpersons for the first session. It's my privilege to invite Dr. Neerja Bhatla. Dr. Neerja Bhatla is the head department of obstetrics and gynecology at All India Institute of Medical Sciences, but I think everyone knows her globally as she's the FIGO member. And I think we are all very much, appreciate her inputs and her contributions, especially for bringing in the FIGO 2018 cervical cancer as well as the vulvar cancer. We have another chairperson, Dr. UD Bafna. Dr. UD Bafna is a very eminent GYN oncologist, and he is presently the head department of gynae oncology at BM Jain Hospital, Bangalore, and he had been the head of the department of gynae oncology earlier at Kidway Memorial Research Institute, Bangalore. We have Dr. S.K. Giri with us. Dr. S.K. Giri is the former professor at PGIC Cuttack, and we know him very well, and he had been the president Association of Gynec Oncologists of India, and I think he's a very active contributor to the gynec oncology, to the association. With this, I request all the chairpersons to start this session, and I hand over to them.
Hello. Thank you, Rama, for the nice introduction. And I would like to thank the entire team of Fortis Hospital for inviting me for this particular session on gynecological oncology. I don't see Dr. Neerja and Dr. Giri here. So without wasting much time, let me start the session. This is, I think, a year in nutshell in gynecological oncology by Dr. Rahul Modi. We know that we have had lots of interesting developments in the field of gynecological oncology. Lots of interesting publications in gynec oncology, especially in cervical cancer. Thing where we have interesting data with immune checkpoint inhibitors. Similarly, endometrial cancer, we have interesting data with immune checkpoint inhibitors and sentinel node trial for cervical cancer. And of course, we have a new staging for vulval cancer, where our own Dr. Nirja Bhatla is one of the, authors, one of the members of the expert committee who have formulated the new staging for carcinoma of the vulva. So I think I request Dr. Rahul Modi to give us the nutshell as what has happened in this year. Dr. Rahul?
Yeah. Good evening, all. Thank you, sir, for the introduction. And I think I have submitted the video. Can the organizers? Yeah. Good evening, all. I am Dr. Rahul D. Modi, Clinical Lead and Assistant Professor Gynec Oncology at the Cancer Research Institute, Dehradun. At the onset, I would like to thank Dr. Rama Joshi and the entire organizing committee for inviting me to give this talk. Today's talk, as you all know, is Year in a Nutshell 2021 for Gynae Oncology. Let's come to the objectives of my talk. So, what has been told to me to keep as the objective is to present the most important publications of the year. Of course, they have to be Gynae Oncology focused. It should be must know for people who are interested to know what the developments have been in Gynae Oncology in the year 2021. It should encompass all aspects, including chemotherapy, radiation, and all the surgical developments. So, how was 2021? I am a gynec oncosurgeon, but I should admit that there has been no big bang or practice changing surgery publications in gynae oncology in 2021. Same was the aspect which was raised at the ESGO 2021. Of all the state of art sessions, surgery was missing. But this year has seen a lot of developments coming into the top in the area of targeted therapies. There has been some good phase 3 radiation trials in cervical cancer management. For the session, I have gone through all the publications, all the plenary sessions and abstracts which were presented at SGO, ASCO, ESGO and IGCS meetings. Let's start with the developments in radiation. Starting with the trial named as the STARS trial, this trial comes from China. This was published in January in JAMA Oncology. In this trial, the importance of this trial is that there is no current consensus on the role of chemotherapy in addition to the radiation for post-operative adjuvant management in early stage cervical cancers who are operated with adverse pathological factors. To start with, the adverse pathological factors this trial considered was the all three major factors, which is positive nodes, positive parametria, positive margins. In addition to it, they also considered LVSI positive as well as outer one-third of cervical stromal invasion to be positive. So they tried to evaluate three different type of regimens, which is a sequential chemoradiation, concurrent CTRT, we all know, radiation alone. So what was done in sequential chemoradiation was that they gave 2 cycles of Paclitaxel prior to radiotherapy, then radiotherapy, and then 2 cycles. Very similar to what we see as a sandwich therapy. So they evaluated the efficacy of all these three different kind of regimens. This was in early cervical cancers. This is as per the FIGO, the old FIGO 2009, 1B to 2A stage. The primary outcome was 3-year disease-free survival. So when we look at the data, it's a large trial. It comes from 1,000 odd patients, 350 in each group. The baseline demographic, everything was balanced except one thing, that the lymph node involvement was lowest in the radiation group. Still, when we look at the results, the sequential chemoradiation scored better than the other two regimens. So when we compare sequential chemoradiation with radiation alone, the 3-year DFS rate is 90% versus 82%, with a HR of 0.52. And when you compare sequential with concurrent chemoradiation, which is a standard of care now, the HR is around 0.65. So let's look at this visual abstract which I've taken from JAMA Oncology. 8 hospitals in China, 1080 patients. We can see the different 3-year DFS rates. Look at the DFS rate of RT, it's 82%, concurrent chemoradiation 85%, sequential chemoradiation 90%. Conclusion was that sequential rather than concurrent, although much more better than radiation alone, should be the future standard of care in giving radiation among women with early stage cancers with the mentioned adverse factors. Let's come to the second study, which was presented at ASCO 2021, the Outback trial. This trial comes with the background that we all know the standard treatment for advanced cervical cancers has been chemoradiation. So, where all the indications where we are giving primary chemoradiation with a curative intent, this trial comes from the GCIG, which is the intergroup we all know. They planned to give in the adjuvant setting, that once you finish the entire chemoradiation, give 4 cycles of Pacli plus carbo in the adjuvant setting, just to see the primary endpoint was overall survival at 5 years, secondary endpoint was progression-free survival and adverse events with patterns of disease recurrence. Let's look at the results, what were presented at ASCO, even at SGO. It's a large trial. It's around 930 patients, 450 odd in each. Adjuvant chemotherapy was only taken by 78% of women who were assigned to receive it. The median follow-up was 60 months. If we look at the overall survival at 5 years in adjuvant versus control, no difference. It's 72% versus 71%. The hazard ratio 0.91. Even if you look at the secondary endpoint in this trial of PFS at 5 years, it's 63% versus 61%, hazard ratio 0.87. The adverse events, as expected, were more in the adjuvant chemotherapy arm, 81% versus 62%, but there was no evidence of differences in adverse events between treatment groups when you go beyond 1 year of randomization. I think this has come in many more trials that the effect lasts for some time between 1 year and 2 years. The patterns of disease recurrences, of course, I don't have the entire slot because it was just presented as at ASCO. The paper hasn't come up. The disease recurrence, the pattern was similar in both the treatment groups. In conclusion, adjuvant chemotherapy given after standard cisplatin based chemoradiation for women with locally advanced cervical cancer does not improve OS or PFS. Let's look at this third study, which is the Embrace 1 study. We saw the world is actually looking at how to improve the outcomes in cervical cancer, either changing the sequence of regimen, adding chemotherapy in the adjuvant setting. This study actually looked at improving or adding image guided therapy in brachytherapy. It was you give chemoradiation followed by MRI based image guided adaptive brachytherapy. So this is again a large study from different centers. Even Tata Memorial Hospital in Bombay was a part of it. So it again includes all the factors, squamous cell carcinoma, adenosquamous and adenocarcinoma, where chemoradiation has to be given. So they gave chemoradiotherapy plus followed by MRI based image guided adaptive brachytherapy. They wanted to see the local tumor control and what is the morbidity data which comes. So at the median follow-up of 51 months, the 5-year control, local control was 92%. Look at the events, 6.8% adverse events for genitourinary, 8.5 for gastrointestinal, 5.7 for vaginal, 3.2 for fistulae. Traditionally, they say that it is 15, the local control factor is 15 to 17% better than traditional in absolute differences. They say that the trial represents that it is a positive breakthrough in the treatment of locally advanced cervical cancer, which might be used as a benchmark for future clinical practice. We look at some charts, look at the 5 year control for all stages. It's even for the stages of 3B, which we commonly see in our OPDs, the local control is around 90%. Let's now see what are the developments in chemotherapy in gynec oncology in 2021. Starting with what was presented at the ASCO meeting this year, the BOOST trial. We all know about ICON 7, GOG 218, telling bevacizumab in maintenance setting, but the standard was 15 cycles. The dose they use here is 15 milligram per kg for bevacizumab. All eligible patients who underwent primary cytoreductive surgeries followed by 6 cycles of paclitaxel. They were stratified into two groups, bevacizumab either for 15 months or either for 30 months. 30 months is an experimental arm. The primary endpoint was PFS. Secondary endpoint was OS, objective response rate, quality of life, safety, and tolerability. Let's look at the results. 927 women from 161 centers, median age 61 years, 96% have an ECOG status of 0 or 1, 58% was R0 resection, 77% had were high grade serous histology. Let's look at the adverse events which happen between 15 versus 30 cycles. So hypertension, we know it's more with 30 cycles. For that's 4.5% versus 2.7%. Thromboembolic events slightly more. Fistula, surprisingly much more in the 15 cycle group. Gastrointestinal perforation marginally more in the 30 cycles. Hemorrhage and myocardial infarction more in the 30 cycles group. Let's look at the chart which was presented at ASCO from the slide there. Uh, no difference in PFS or OS. HR for 15 versus 30 is 0.99. If you look at the overall survival HR, it's just 1.04. Conclusion, longer treatment with bevacizumab for up to 30 months neither improves OS nor PFS as compared to 15 months. So, at present, 15 months just remains the standard of care. Let's come to the Ariel 4 study, which was presented at SGO 2021. Of course, we know the PARP inhibitors, they are the drug of the decade in gynae oncology. So here we look at the rucaparib data. So this was in BRCA mutated advanced relapsed ovarian cancers. The group actually divided into three parts. It's platinum resistant, partially platinum sensitive, and fully platinum sensitive. So they give rucaparib after treatment. For example, if it is platinum resistant, they give single agent paclitaxel. For sensitive, they gave the doublet, which was either paclicarbo or paclicis or lipodox carbo, and then rucaparib was given as maintenance regimen. So here we look at the rucaparib data. It was in 2:1 pattern. Look at the serous histology. It's around 90% of the cases. ECOG status, most of them have ECOG 0. Look at the germline status. Germline mutation, 85% in the rucaparib, 81% in the chemotherapy. Somatic mutations around 15% in both the arms. This trial was in recurrent ovarian settings after two or more than two chemotherapy regimens. So we look at the platinum status. Most are platinum resistant. Even if we look at the rucaparib arm, it's 51.5% and 51% in the chemotherapy. The results. These are the PFS which were presented at SGO. One is the efficacy base and other is the intention to treat PFS. Both shows clear benefits to rucaparib. Hazard ratio 0.64, hazard ratio 0.67. So almost a protection effect of almost 40%. Let's now shift to endometrial cancers, the keynote 775 or the study 309, again presented at SGO 2021. Look at the eligibility criteria: advanced, metastatic, or recurrent endometrial cancers, one prior platinum based chemotherapy, ECOG status 0 or 1. Tissue should be available for MMR testing. How did they stratify? It was proficient versus deficient MMR status. It's again a large trial. They divided into 1:1, lenvatinib plus pembrolizumab versus single agent doxo or single agent pacli as per the physician choice. The primary endpoints were PFS and OS. Secondary endpoints included quality of life, safety. Let's look at the results. Look at the progression free survival in the MMR proficient and all comers. Uh, Almost the same. It's 0.60 and 0.56. Again, look at the overall survival. No difference when you differentiate between proficient versus all comers. Definite advantage when you look at chemotherapy versus lenvatinib with pembrolizumab. So the conclusion: lenvatinib plus pembrolizumab demonstrates a statistically significant and clinically meaningful improvement in PFS OS in advanced endometrial cancers, which are both proficient MMR and deficient MMR, irrespective of the MMR status, and the safety profile is manageable. Again, coming to PARP inhibitors, it's a recently published Lancet paper, the Solo One maintenance data, which has come as a 5-year follow-up to the trial. Again, in primary setting, they gave olaparib 300 milligrams BID. The PFS benefit with maintenance olaparib, which was evaluated whether it has a sustained benefit beyond 2 years with a median follow-up of almost more than 4.5 years. The median PFS is still not reached with olaparib. So again, a HR of 0.46, 0.33. Definitely what we are looking at, all the studies, if you look at overall PARP inhibitors, they are giving this hazard ratio and benefit of around 50 to 60% against what was standard till now. Moving on from PARP inhibitors and immunotherapies and targeted therapies, this is an interesting paper which comes from JAMA and Oncology. We all have experience of how to treat frail old patients with advanced ovarian cancer, and we always keep our bets on single agent carboplatin till the PS improves and then we shift to doublet. So this study actually looked at efficacy and safety of first line single agent carboplatin versus carbo plus pacli for vulnerable older adult women with ovarian cancer. So this looks at the objective of the study was whether it is feasible, the efficacy and the safety of single agent carbo. They also looked at weekly pacli carbo versus conventional every 3 weeks pacli carbo. So it is all the settings which we consider in our day-to-day life. It's an international open label phase 3 trial, 447 women, 70 years plus, all diagnosed with stage 3, 4. They looked at the geriatric vulnerability score. Most of them have vulnerability score of 3 or higher. Let's look at the results. Uh, a total of 120 women were randomized between these three groups, uh, between a single agent carbo, a weekly pacli carbo, and the conventional 3 weekly pacli carbo. The mean and the median age 80 years. That's quite a lot. 36% has had the geriatric vulnerability score of 4. The 5, which is the highest, is around 11%. One third of them have stage 4 disease. But the committee, after having its independent data monitoring committee, recommended that we should terminate the single agent arm because it was associated with significantly worse survival. Look at this visual abstract from JAMA Oncology. 48 centers, 120 women, 40, 40, 40 between the three arms, but clear cut the trial had to be terminated because single agent carboplatin was showing much more worse results than weekly pacli carbo or every 3 weekly pacli carbo. Of course, from all the three, the conventional pacli carbo is the best as per this trial. Let's now come to my forte, surgery in gynec oncology. As I've always already admitted, not much this year, but definitely, I promise next year we'll come hard. Let's look at this paper from the American Journal of Obs-Gynae. We all know we are living in the LAC era where minimally invasive surgeries and uterine manipulators are looked at with a doubt. So this study evaluates impact of uterine manipulator on oncological outcomes in endometrial cancer surgery. We all know the oncological outcomes might be influenced by the uterine manipulator, but uh, in endometrial cancers, in minimally invasive surgery, uh, the data is limited. The current evidence all comes from retrospective studies, but with a limited sample size. So, this is a large multicentric retrospective study which looks at the oncological safety data of the uterine manipulator. They also look at other factors also which influence the disease, the histology, LVSI, FIGO stage. The primary objective was to look at the relapse rate. The secondary objective was to determine the recurrence-free survival, overall survival, and the patterns of recurrence. So I told it's a large data. It's around 2661 women from 15 centers, out of which 1750 odd underwent hysterectomy with a uterine manipulator, 905 without it. Both the groups were balanced with respect to histology, tumor grade, myometrial invasion, FIGO stage, and adjuvant therapy. So you take care of these confounding factors. Look at the rate of recurrence: 11.69% in the uterine manipulator, 7.4% in the no manipulator. Statistically significant. Risk of recurrence, hazard ratio, it's 2.31. So, the use of uterine manipulator. Let's look at the data for early endometrial, which is the uterus confined endometrial cancers. Again, hazard ratio of 1.74. And interestingly, in the pattern of recurrences, there is no difference which was found in the pattern of recurrences. Let's look at this chart. Overall, if we look at the hazard ratio, 2.3 times bad. Let's look at the FIGO stage 1A to 2, hazard ratio 1.64. Look down, FIGO stage, uterus confined endometrial cancer with a uterine manipulator, hazard ratio 1.74. So almost two times bad. Conclusion: use of a uterine manipulator was associated with a worse oncological outcome with uterus confined endometrial cancers who underwent minimally invasive surgery. Still, since it's a retrospective study, we require prospective trials essentially to confirm these results. Let's now go to HIPEC, the another interest in surgery in gynae oncology in recent times. This is a small phase 3 clinical trial which is published now in Annals of Surgical Oncology. We all know about the Vandrel trial. It showed benefit on the HIPEC arm in the interval CRS. This is a single center prospective parallel group phase 3 RCT, only 71 patients, 36 in CRS versus 35 in CRS plus HIPEC, cisplatin 75 milligram per meter square. We have seen data in the Vandrel was 100 milligram per meter square. Primary endpoint, DFS, secondary endpoint, OS and morbidity. Let's look at the results. Median follow-up of 32 months, DFS 18 versus 12 with the benefit to HIPEC with hazard ratio of 0.12. Look at the OS data, 52 months for HIPEC, 45 months for CRS only. Morbidity, no much difference. Mortality, around 3% in both. The result, of course, very small trial, again shows a benefit to the HIPEC in interval cytoreduction. So now let me conclude in a nutshell. What are the takeaways? First, more is not always better. We look from the Outback and the Boost trial. Outback trial, no advantage of adding adjuvant to chemoradiation. Boost, no advantage of bevacizumab 30 months versus 15 months. Second, this year saw a lot in the field of locally advanced cervical cancer. What more can be done to improve the outcomes? There was Outback Of course, it's a negative trial, STARS trial, which looked at early cervical cancers. Then we had EMBRACE to use technology of MRI-based image-guided brachytherapy. More is happening on targeted therapy arms. Molecular is the new hero. We know from lenvatinib and pembrolizumab studies, many other studies maturing with different drugs, Garnet study. Data is yet to mature, but definitely molecular is the new hero. PARP inhibitors, they are showing sustained benefits with the solo 1 5 year data. We look at it, PARP inhibitors are continuing their benefits in ovarian cancer management. Coming to the surgical aspect, uterine manipulator, again a suspicious agent. It's being a culprit in all the trials with minimally invasive arm in uterine as well as cervical cancer. HIPEC, more studies are needed where we look at bevacizumab in upfront setting, PARP inhibitors, some studies are coming up when you treat in upfront setting. At that time, whether HIPEC stays with its relevance with because the trial presented this time is it's just 70 patients. So to end, we saw all the developments and thank you all. I know Omicron is coming. Mask up, get vaccinated, report early. All of you have a great time ahead.
Thank you, Rahul. Very interesting presentation. I think some of the publications which you have quoted, I would not like to believe them. Something different from what we have been practicing. For example, you quoted about radiation, the STARS trial, where they've shown that sequential radiotherapy, that is, give chemotherapy, radiotherapy, and again followed by chemotherapy. So it has shown improvement in DFS as compared to concurrent chemo radiation, which has been standard of care for all these years. So this has come as something different news to me. I think we need to have some more studies before it becomes standard of care. And then Outback trial, I think you mentioned that more adjuvant chemotherapy for advanced cervical cancer is not beneficial. But they have excluded patients with aortic lymph nodes. So I think some of the patients with aortic lymph nodes might benefit from additional adjuvant chemotherapy. We don't have the answers, but at present, additional chemotherapy has got not much benefit, as shown by the Outback trial. Then I think you have quoted the Embrace trial. Tata Center was one of the, I think, investigator. A very interesting study. MRI guided brachytherapy, I think, improves the local control rate in advanced ovarian cancer. I think this should become standard of care, especially in our country where we have many patients with advanced cervical cancer. And then coming to chemotherapy, very interesting, bevacizumab, additional duration 15 months versus 30 months. 30 months does not give any kind of advantage. So standard of care remains 15 cycles of bevacizumab. No point in giving any more cycles of bevacizumab. Then as far as PARP inhibitors are concerned, I think all the trials, all the PARP inhibitors, rucaparib, olaparib, and niraparib, all the trials have shown benefit both in the primary setting as well as in the relapsed setting. Very, I think, very effective drug. Unfortunately, in our country, many of the patients are not able to afford these kind of therapies. And you presented endometrial cancer, the role of immune checkpoint inhibitors, lenvatinib with pembrolizumab versus chemotherapy. It has shown improvement in survival in advanced endometrial cancer as well as recurrent endometrial cancer. It has shown improvement in both PFS and overall survival in both MMR proficient as well as MMR deficient, both. But I think the NCCN guidelines have recommended this only for MMR deficient, if I'm not wrong. It's
Yes,
not
sir.
recommended for MMR proficient endometrial cancer. I don't know what is the reason for that.
I think, sir,
yeah,
because I think they have not recommended because the previous studies were phase 2. So this is the first phase 3 RCT.
yeah.
So that's why maybe the level of evidence maybe not that much is
Okay.
maybe the reason.
Okay. Then you quoted a very interesting Solo 1 trial, the 5-year follow-up with olaparib, tremendous improvement in PFS 1, 56 months compared to 13.8 months with placebo. Tremendous improvement in PFS. PFS 2 is not yet reached. So I think very good drug as a maintenance therapy for epithelial ovarian cancer. Probably all the platinum sensitive patients might benefit from olaparib maintenance therapy. Very good drug. And one more trial, interesting trial, single agent carboplatinum versus combination chemotherapy, weekly or conventional 3-weekly in frail patients. I'm really surprised that carboplatin has not done well. Still, I think many of us are still not very comfortable using combination chemotherapy in very, very frail patients. But I think the standard of practice needs to be changed, and we need to have our own experience. And lastly, coming to the role of surgery, uterine manipulator, you said, has got an adverse impact in endometrial cancer, but this is a retrospective study. And if you do a prospective study, you might find altogether a different result. Why uterine manipulator should cause increased recurrence rate, I'm not very sure. Cervical cancer, you can understand, but endometrial cancer, I'm not very sure why uterine manipulators should cause increased risk of recurrence. And lastly, I think you presented that IPEC after neoadjuvant chemotherapy is beneficial in improving both PFS and overall survival. So altogether, I think very interesting year and very nice presentation, Rahul. Thank you so much.
Thank you so much, Dr. Bafta, for sharing it wonderfully well. We have, I think it's a short of time, and we have to go to the second session of the Gynae Oncology, where we have 2 papers to be presented. So I invite the chairpersons, Dr. Jaideep Bhaumik. I don't know whether he is logged in. Dr. Jaideep Bhaumik.
Yes,
Dr.
he is there.
Yeah. So can we have the introduction? Dr. Jaideep Bhaumik is heading the Department of Gynae Oncology at Tata Center, Kolkata. And Dr. Bhagya Lakshmi Nayak. Dr. Bhagya Lakshmi is around? Dr. Bhagya Lakshmi.
Can you hear me?
Yeah. We can hear you, but I can't see you anyway. So Dr. Bhagya Lakshmi is the professor of Gynae Oncology at Acharya Harihar Regional Cancer Center, Cuttack. Dr. Rupinder Shekhon. Dr. Rupinder Shekhon needs no introduction, and she is the chief of the GYN Oncology at Rajiv Gandhi Cancer Institute, Delhi, and she is presently the Secretary General of AGOI. With this, I hand over to the chairpersons for this interesting session. Thank you.
So good evening. It's only a few days that we had the Desktop 3 trial published. Of course, we have been talking about it for a long time. And within a few days now, we are here listening to the trial. I'm looking forward to it. I'm just a small note that I'm actually in my operating theater. I may be called away anytime, but as long as I can stay, I will stay. Please carry on, Dr. Swasti, please.
Dr. Swasti, please go ahead.
Ma'am. Okay, ma'am.
So she is a senior consultant in Gynae Surgical Oncology at Max Institute in Vaishali.
Please play the video. Please play the video.
Arnab, please start the video.
Good evening, friends. Today I'm going to talk to you about the Desktop 3 trial. And this is actually an interesting trial which showed improved survival with secondary cytoreductive in patients with platinum-sensitive recurrent ovarian cancer. It's a randomized controlled phase 3 trial study and evaluates the impact of secondary cytoreduction in recurrent ovarian cancer. We're going to talk about the final results in the allocated time. So the background is, how did this desktop selection criteria came and how the study came into existence. So we know that surgery and chemotherapy are the cornerstones of ovarian cancer therapy. However, role of secondary cytoreductive surgery for recurrent ovarian cancer so far are not fully defined by randomized surgical trials. If you look at the AGO Desktop 1, they developed a hypothesis for a predictive score to identify patients who had a complete resection during secondary cytoreductive surgery. And this score consisted of 1, good performance status, ECOG 0, 2, complete resection during first-line therapy, and 3, ascites less than 500 ml. The AGO Desktop 2 evaluated the score in a prospective multicenter trial in patients with platinum-free interval of 6 months or more in that means platinum-sensitive recurrent ovarian cancer, and confirmed its predictive value. So 51 patients had a positive AGO score, and it could predict with 95% probability complete resection in more than 2 of 3 patients. So the current study reports the final analysis of a randomized control phase Desktop 3 trial evaluating the survival benefit of secondary cytoreductive surgery in selected patients with platinum-sensitive recurrent ovarian cancer. So if you look at this trial, this opened in 2009, you do not have a large number of surgical phase 3 trials for recurrent disease. There are lots of problems. Plan numbers usually are not reached. Low recruitment and premature termination is usually the dictum in these kind of situations. So the Desktop 3 trial was completed successfully. And there was a standardized patient selection. 407 patients were taken with first relapse and platinum-sensitive recurrent ovarian cancer. This was done in 80 centers over 12 countries, recruited over the period of 5 years. 407 patients were evaluable. Primary endpoint was overall survival. Key secondary endpoints were PFS, resection rate, treatment burden, and planned interim analysis showed PFS benefit for surgery. So how they were randomized: 400 patients randomized 206 to cytoreductive surgery with maximal effort for complete resection, followed by platinum-based combination therapy, which is strongly recommended. Followed by a second randomized arm was the no surgery arm, where 201 patients were immediately started on platinum-based combination chemotherapy, which was strongly recommended. So the first endpoint was overall survival. This analysis was presented at ASCO 2017 and showed significant PFS benefit for surgery. The database closure was done in 2020 after 254 of 244 planned events. If you look at retrospective studies, what do we have at the moment of international pooled analysis as far as secondary cytoreduction for ovarian cancer is concerned? If you have early stage disease, you have 0 residual tumor after primary surgery, you have a progression-free interval of more than 16 months, or an ECOG performance status 0 to 1, less than 105 value of CA-125 at recurrence, and no ascites. These patients tend to do fairly well. So if you have a resection rate of resection 0, R0 status, you have a median survival, whooping median survival after secondary cytoreduction of 57.7 months, vis-a-vis R1 of 27 months and R2 status of 15.6 months. So how much you are taking out at surgery is critical. And if you look at the Desktop 3 patient characteristics, usually 90% of patients in each arm received platinum-based chemotherapy after randomization. We looked at the total number of patients in each arm, and the median patient-free interval was 18.7 months in no surgery versus 21.1 months in surgery arm. And if you look at therapy after randomization, well, most of them received platinum-containing therapy. Bevacizumab was given in 23.4% and 22.8% respectively in the no surgery versus surgery arm. And if you look at the surgery arm, you have a macroscopic complete resection rate of 74.2% with 35.8% of GI resections, a 250 ml of blood loss, about 0.5% of 30 or 90-day mortality, and a real laparotomy rate of 3.7%. And if you compare surgery versus no surgery arm, and you look at progression-free survival in the intention to treat population, there's a difference of 5.6 months more median PFS in surgery arm versus the no surgery arm, 19.6 months versus 14 months, which is quite significant, with a p-value of less than 0.001. And if you compare progression-free survival by surgical outcome, and you compare all three situations where there's no surgery, surgery with residual tumor, almost similar, median PFS of 14 months and 13.7 months. Whereas if you do a surgery with complete resection rate, you have a significant improvement in the median PFS of an absolute value of 21.2 months. So there's definitely a climb of 7.2 months in this arm. If you compare surgery and no surgery arm and look at overall survival in the intention to treat population, you have a p-value of 0.02 and an improvement in the surgery arm of median overall survival by 7.7 months. And if you look at post hoc subgroup analysis and look at only surgical arm and see what amount of tumor has been removed. So post-op status, if you have residual tumor, you have a low median overall survival of 28.8 months vis-a-vis of 61.9 months in complete resection. So complete resection seems to be the real key, and there is no doubt about it. So if you look at median overall survival, no surgery versus complete resection, again, no surgery is 46 months, p-value is less than 0.001, and surgery with complete resection with an improvement of 15.9 months stands at 61.9 months. So to conclude, I would like to say that the desktop set said that secondary cytoreductive surgery can have significant clinical benefit in selected platinum-sensitive recurrent ovarian cancer patients predicted to have high likelihood of complete resection. Cytoreductive surgery significantly prolonged overall survival, progression-free survival in patients with platinum-free interval more than 6 months and positive AGO score, complete resection rate of 75% in identified patients. Complete versus incomplete resection increased median overall survival by 33.1 months and reduced risk of death by 60%. Investigators recommend patients should receive eligibility screening for cytoreductive surgery and counseling about potential options at the time of recurrence. And Desktop 3 is the first prospectively randomized trial which shows an overall survival benefit of debulking surgery in recurrent ovarian cancer. Cytoreductive surgery for patients with a progression-free interval of more than 6 months and selected by AGO score significantly prolonged overall and progression-free interval. The overall survival benefit was highest and exclusively seen in the cohort with complete resection, which indicates the importance of a thorough selection process of both the right patient and the right center. A quick glance on the treatment algorithm for relapsed ovarian cancer patients in the first relapse and where the progression-free interval is more than 6 months and a good AGO score with the appropriate capacity and competence of the center available, offer cytoreductive surgery, do a complete resection, and immediately start platinum-based therapy and put them on PARP maintenance. Otherwise, you just have the option of giving platinum-based therapy plus bevacizumab if possible and put them on PARP maintenance. Thank you so much for your patient hearing, and I'll be happy to answer questions if any.
Yeah, Dr. Bhagia.
Yeah, I think Swasti, it is really very interesting, but do we have any questions in the chat box?
Ma'am, there are none questions in the chat
No,
box.
I don't think so.
Okay. So I just have a comment that I think Desktop 3 is one of its kind prospective trial in surgical gynae oncology. And I think the best message that should go from this trial is that you have to choose your patients very correctly. So that's the most important thing that you should do. And secondary cytoreduction really does have a very important role to play in ovarian cancer patients. But the only crux is that you choose your patients very well. That's more important.
Thank you, ma'am.
Yeah, that's right. Patient selection is the most important criteria.
I haven't had a chance to read the entire article thoroughly, but I've just gone through it like a skim reading. And what appeared to me exactly what you just said is that I doubt how many of our patients will actually fit in those criteria. Maybe less than 25% of our patients will actually fit into the criteria of the desktop trial. When majority of our serous carcinoma patients will recur with peritoneal carcinomatosis, out of question, they will probably not have a complete cytoreduction in the first place anyway. So there are lots of constraints we face when treating our patients in our country. And again, when patients will have to pay for their treatment, how many can afford to pay for a second-time surgery? So all these constraints are there, but it's a very good trial, looking for at least something good for the surgeons.
Yeah, but see, it's not only that how many of our patients, it is how many of the overall patients come to you with, just one small recurrence and no ascites and or minimal ascites and CA125 value, which is so low. So, I mean, very, very few patients actually fit into this criteria. But however, no matter how few those patients are, I think we should definitely give them a fighting chance and go ahead with the cytoreductive surgery. That's true.
I think, ma'am, patient compliance and how strict is our follow-up would also determine how many patients would we be able to offer secondary cytoreduction in the future. I think picking up early recurrences.
No, that is true. But then we do see patients, even though they are, pretty regular in the follow-up, still they come back. They've been fine, and the next time they come back, it's florid disease. So I think.
Yeah, maybe they behave a little differently, but then again, we have to pick them up very judiciously.
In time, that's right.
Ma'am, can we invite the next speaker, ma'am? We're just running short in time. So may I request Dr. Sikam to please invite the next speaker.
Can we have the CV or something?
Yes.
Okay, so next we have Dr. Rajat Saha. He's currently the Associate Director of Medical Oncology at Max Hospital, Patparganj and Vaishali. And he's going to be talking to us about pembrolizumab, which is actually the new kid in town for recurrent or metastatic cervical cancer. Remembering all the time that it was actually bevacizumab, which was the first drug which was approved for metastatic cervical cancer. Welcome, Rajat. The stage is all yours. Happy to see you here.
So can we have the video, please?
Good evening, dear friends and colleagues. I would like to thank the organizers for giving me the opportunity to discuss a very recent, fresh from the oven trial, the Keynote 826 trial on pembrolizumab for persistent, recurrent, or metastatic cervical cancer. This trial was published in the New England Journal of Medicine on November 11th, 2021. Conducted by Colombo et al. This is a multi-center trial conducted in approximately 191 centers in 19 countries. Let us come to the background of this trial. The background is a Keynote 158 trial was conducted. This trial was basically a basket trial, and it was a phase 2 multi-cohort study of pembrolizumab in various advanced solid tumors, in which pembrolizumab was given at the standard dose of 200 milligrams IV every 3 weekly, and these patients were treated for 2 years until progression. Now, in this basket trial, if we analyze the cohort of cervical cancer patients, there were about 98 patients of cervical cancer in this Keynote 158 trial. And here, if we just switch on to the summary of the response in these cervical cancer patients, with single agent pembrolizumab, the overall response rates have been in the range of 12.2%, and in the PD-L1 positive patients it has been around 14.6%, and in the PD-L1 negative was around 0%. So with an encouraging 14.6% in a heavily pre-treated cervical cancer cohort. So with this background, the Keynote 826 trial was designed. So this is a double-blind, multi-center trial in 151 centers in 19 countries. So this is where what we can see is the Keynote 826 study schema, in which the patients, there were approximately 600 patients of persistent, recurrent, or metastatic cervical cancer not amenable to any curative treatment. There was no prior systemic chemotherapy. So this is basically the first line therapy for metastatic or recurrent metastatic tumors, and prior radiation or radiosensitizing chemotherapy was allowed. Obviously, as in all trials, the ECOG performance rate of 0 to 1 was chosen, and these patients were randomized to pembrolizumab 200 milligrams IV every 3 weekly, plus the standard of care paclitaxel at 175 milligram per meter square, cisplatin 50 milligrams per meter square, or carboplatin AUC 5 as per the investigator's choice, and also combined with bevacizumab at 15 milligram per kg intravenous. So this was the study experimental arm, and in the placebo arm, we had the standard chemotherapy plus minus bevacizumab with a placebo. So the treatment was continued until disease progression or unacceptable toxicity or any voluntary patient withdrawal. So pembrolizumab was continued for a period of approximately 2 years. So approximately 35 cycles of pembrolizumab could be given in this trial, and chemotherapy was limited to 6 cycles of chemotherapy. So the prior stratification was based on the metastatic status at diagnosis, planned bevacizumab use, and the PD-L1 status, with a combined positive score stratification at less than 1%, 1 to 10%, or greater than or equal to 10%. So the endpoints chosen for this Keynote 826 first-line pembrolizumab in metastatic cervical cancer was that there were dual primary endpoints of overall survival and progression-free survival. There were secondary endpoints like the percentage of patients with a confirmed partial or complete response, the duration of response, the percentage of patients who were alive without disease progression at 12 months. So this was the patient flow in the entire trial. About 883 patients were screened and 617 finally underwent randomization. And in a 1:1 fashion, 308 were assigned to the pembrolizumab plus chemotherapy arm, and 309 patients were assigned to the placebo plus chemotherapy arm. So this was the flow of the patients, the distribution of the patients. Needless to say, all the patients in the demographic profile were well matched in terms of the stage of the disease, in terms of the histology of the disease. And what we found out that in this trial, about 72.3% of the patients had squamous cell carcinoma. And the data cutoff for the first interim analysis in May 2021 was at 22 months from randomization. So this paper, in this NEJM article, this paper presents the results of the pre-planned interim analysis at 22 months. So this trial has still not matured enough, but this was the pre-planned interim analysis. So this is what we are here to discuss. So coming to the results of this trial, this landmark trial. So the first primary endpoint was the progression-free survival. So progression-free survival and the overall survival both were taken in three different in three population of patients. First was the PD-L1 percentage greater than 1%. Second was in the intent to treat patients, and third was in patients with PD-L1 greater than 10%. So these three population of patients were taken. Obviously, this population is mutually inclusive; they are not exclusive. So let us come to the first Kaplan-Meier curve, the first result of this trial, the progression-free survival in PD-L1 greater than 1%. So here we can see that the Kaplan-Meier curves are separating quite early on at approximately 3 months, and they are continuing to separate down the line also. And the progression-free and the PFS advantage at 22 months, which is the interim means planned analysis, was 38%. So there was a 38% improvement in PFS, and in the pembrolizumab cohort, the progression-free survival was at 10.4 months, and in the placebo cohort, the progression-free survival was at 8.2 months, and it was statistically highly significant at 0.001. Let us come to the progression-free survival in the intent to treat patient population. And here also we can see that there was a 35% improvement in the progression-free survival at 22 months. And in the pembrolizumab cohort, it was 10.4 months. And in the placebo cohort, it was 8.2 months. Remember that in the PD-L1 greater than 1% also, it was almost similar, the progression-free survival figures. Let us come to the progression-free survival in PD-L1 greater than 10%. In this population of patients, here we can see that there was a 42% improvement in the progression-free survival, and in the pembrolizumab cohort, the PFS stood at 10.4 months, and in the placebo cohort, it stood at around 8.1 months. Here also, in this curve also, we are seeing that the curves are separating very early on in the trial. That means at around 2.5 to 3 months, and they continue to separate widely down the line also. This is the forest plot analysis, thus various subgroup analysis which have been performed as far as the progression-free survival is concerned. And here we can see across almost all the parameters like age, race, ECOG performance score, PD-L1 score, concomitant bevacizumab, yes or no, or metastatic disease, yes or no. Pembrolizumab has been fairly consistent in giving a good a very significant hazard ratio. Only in PD-L1 less than 1%, it is not showing much of a significance. But however, the numbers here are very small. It is only 69 patients. So that's why we may not draw any major conclusions from this. Let us come to the second primary endpoint of this trial, the overall survival. Again, we are going to analyze it in the three population subsets. First, in the PD-L1 greater than 1%. So in this PD-L1 greater than or equal to 1% population, here we can see that there was a 36% improvement in the overall survival, and the pembrolizumab cohort, the overall survival was not reached, and in the placebo cohort, the overall survival stood at 16.5 months. So that was highly statistically significant. The overall survival in the intent to treat population again showed a very good improvement with a 33% improvement in overall survival, with the pembrolizumab cohort showing around 24.4 months and the placebo cohort 16.3 months. So good delta of around 8 months seen with the usage of pembrolizumab in the intent to treat population. Again, in the highly selected population of PD-L1 greater than 10% patients, so if we can analyze the overall survival Kaplan-Meier curves, here also we can see that there's a 39% improvement in overall survival at 22 months, with the pembrolizumab cohort not the median overall survival not reached, whereas in the placebo cohort it is at 16.5 months. So all the subpopulation of cells, whereas whether the PD-L1 is equal to or greater than 1% or greater than 10%, or in the intent to treat population, all of them are showing that pembrolizumab is definitely improving the overall survival. So this is the subgroup analysis as far as the overall survival is concerned. Here also we can see that most of the patients in almost all the subgroups are favoring the use of pembrolizumab with a good hazard ratio varying between 0.5 to 0.3. The only thing is that again, in this small subset of patients in this PD-L1 less than 1%, we are not having much of a significance. So here, this is the only small subset of population in which we may not like to start with pembrolizumab. Now, whenever we are adding any new drug to the existing standard of care, we are always worried about the side effect profile, the adverse effect profile, whether we would be able to manage it or not. But here we can see in the pembrolizumab group versus the placebo group, there was no major safety signals or there was no major increase in the adverse effect profile. So there was it was pretty well tolerable, and no new safety signals are there. So to conclude this very significant trial, So there was a significant improvement in the progression-free survival and overall survival, irrespective of the PD-L1 status. So as long as the PD-L1 status is at 1% or more than 1%, we can give pembrolizumab as the first-line treatment. There were no major safety concerns. That is also very encouraging. The secondary endpoints of objective response and the response and the duration of response was improved with pembrolizumab. The proportion of the PD-L1 negative population was only 11% in this trial, and it was very small in this study group to draw any conclusion. So my take on this trial is that pembrolizumab is a good partner drug to be employed early on in the disease course, as is evident from various trials in the neoadjuvant and concurrent setting. Nowadays, we are kind of moving up the immunotherapy drugs more in the neoadjuvant and the concurrent setting, and they are definitely yielding better results. So it is definitely a wise decision to use it in the first line treatment of metastatic cervical cancer. Obviously, the cost of 2 years of pembrolizumab is prohibitive for widespread application in our clinics. With that, I would like to end my presentation, and thank you very much for a patient here. Thank you.
So I think that was a very interesting presentation by both by Dr. Swasti and Dr. Saha. I would request the chairpersons and Dr. Rama Joshi for their concluding remarks and closing the session, as we are running a little short of time.
Yeah, so thank you so much for having us as chairpersons, Dr. Rama, and your whole team. As Ranjit himself has said, first of all, the availability of Dream PD-L1 is hardly there in any of the centers in our country. And then, of course, the cost of pembrolizumab is prohibitive. Thank you so much.
Thank you again. Thank you all of you.
So this was a very interesting session. I thank all the presenters as well as all chairpersons who could really take out time out of their busy schedule to make this program very interactive and interesting. Thank you all. We will meet tomorrow again at the same time. We have 2 interesting debates in the gynec oncology. So see you all tomorrow. Thank you.
So thank you all the speakers, chairpersons, and Dr. Rama Joshi for a wonderful session. And with this, I next invite Dr. Meenu Walia. Dr. Meenu Walia is a Senior Director of Medical Oncology at Max Hospital East Zone. And Dr. Meenu Walia will be talking on the bringing precision to newly diagnosed ovarian cancer. Welcome, Dr. Meenu Walia, and please go ahead with your presentation.
Arnab, please unshare the screen.
Can I please share my slides, please? Thank you, Dr. Vinita. Thank you, organizers, and thanks, Astra, for the opportunity. The topic I'm going to talk about is HRD. Is it something beyond BRCA, the new BRCA, or probably trying to bring precision to medicine further? So, ovarian cancer. Just a second. So most patients with advanced ovarian cancer, we know that ultimately relapse following first-line multimodality therapy. Almost 3 lakh patients were diagnosed with advanced ovarian cancer in the year 2018. And almost 2/3 of these, 60 to 70%, are generally diagnosed in advanced stages, stage 3 and 4. And majority of these patients, 2 to 3, again 2/3 of these, 70% or so, they ultimately relapse within 3 years of completing the treatment. So hence, we all agree that there is a significant need for better first-line treatment to improve outcomes in these set of patients. And many of us, all of us will agree with the typical presentation of an advanced ovarian cancer. The patient initially seems to be responding. Initially, most of these patients, they respond beautifully to chemotherapy, and the progression-free interval for majority of them, of course not for all of them, to approximately around a year or so. And then the disease invariably, in majority of them, the disease comes back, and then one needs to go for second line chemotherapy, and then third line, and then so on. And with every subsequent relapse, the progression-free interval seems to become shorter and shorter, and ultimately we lose majority of these cases to the disease per se. So once the disease relapse, it is largely incurable, and hence, can we do something add on to the first line treatment for these patients to achieve a potential cure, or probably delay the relapse as much as possible? A lot has happened in various cancers, but somehow the ovarian cancer seems to be lagging behind the development in other cancers. We have had a lot of targeted therapies in lung cancers, in breast, etc. So almost 2 decades, it is more than 2 decades that Pacli Carbo became the backbone of chemotherapy for ovarian cancer, and nothing much has changed in the chemotherapy. So almost after a decade or so, we had some positive responses with the OCEAN trial and the other trials, which showed that bevacizumab improved the progression-free survival. And not all of us changed our practice, because the OS advantage was not clearly visible, and the PFS advantage was also just a few months only. So 2018, once the results of SOLO trial were published, I would rather say there was a paradigm shift, that now we moved on the PARP inhibitor maintenance for BRCA mutated ovarian cancer in the first line setting also. And closely following this, that was 2019, we now have data for the combination of PARP inhibitor and bevacizumab, and not only in BRCA mutated cancers, but also in BRCA non-mutated cancer, but HRD, but homologous recombinant deficient tumor. So beyond BRCA mutation also, we could identify that there is a subgroup of patients which might benefit from these PARP inhibitors. So coming to the basics of PARP inhibitors, we know that due to various external and internal insults that keep on happening in these cells, there will be multiple DNA damages at multiple levels. Some of them can be single strand damage or double strand repair. And it is not one pathway that corrects this DNA damage. You have the base excision repair pathway, you have the homologous recombination pathway, non-homologous end joining pathway, and micro-homologous end joining pathway. So there are multiple pathways which basically try to repair these damages at multiple levels. And most of these pathways depend also on the PARP enzymes for conducting the damage repair. So what is the end result of all these damage repairs? Either the damage is repaired, or what would have been still preferred is possibly the other thing is either the cells go into senescence, apoptosis, and this prevents carcinogenesis. But however, we also know that very frequently there is a failure to repair this damage, which leads to genomic instability and still happens to remain one of the most fundamental causes of carcinogenesis. What is more to be noted is that we hardly, unlike lung, unlike various other cancers, unlike breast, the actionable mutations that we can find in high-grade serous ovarian cancer or in high-grade ovarian cancer are very, very less. So there is a huge lacuna, there is a huge opportunity to try the new targets or new areas where something can be used, some targeted therapy or something to enhance responses. And genomic instability seems to have emerged as an important key therapeutic target area. So we know there is a subgroup of patients of high-grade serous ovarian cancers or high-grade epithelial ovarian cancers who will have BRCA mutations. But then came the concept of not only BRCA mutation, there's something called as BRCA-ness also, and there are other HRR genes which may be causing the defect similar to BRCA mutation, and it has possibly gone further. You know that it is not the BRCA gene alone, and today's date it may be HRR genes, it may be the FA genes, CDK12 and RAD51 and whatnot. The list seems to be increasing. What is important to know that is homologous recombinant deficiency is present in approximately half, as high as half of these high-grade epithelial ovarian cancers, which seems like a very important thing in the sense that you at least in looks like if such a high is the incidence of these homologous recombinant deficiency, possibly we can make use of this for further targeted therapies. So the concept of synthetic lethality with PARP inhibition, a normal cell having a normal homologous recombination and a normal repair pathways, cell survives. An HR deficient cell and but will still have one alternative pathway so that the cell survives, and PARP inhibition in a normal cell will again the cell will still survive. So it is the basic principle for the postgraduate, just for the sake of postgraduate, the basic principle remains the synthetic lethality in a cell which is HR deficient will the other major pathway that it depends for the DNA repair is the PARP dependent pathway, and the combination of PARP inhibition and in these kind of cells can ultimately lead to cell death. And this is the principle that has been tried wherever we look for these PARP inhibitors. So how do we identify? We know how we have been identifying BRCA mutations, but how do we, if we want to increase our scope further, so how do we identify the homologous recombinant deficiency? So there are two ways of identifying. One is you look at the genes which are causing the homologous recombinant deficiency, and what do you do for that? You either get the BRCA testing done, or you do the NGS done, you do the genomic assays, and where you look for BRCA, RAD and other HRR gene mutation testing, and that may tell us that these are the genes which are present, these genetic mutations are present, which may be a whole subgroup of HRR genes which may be mutated. There is possibly another way to look at the homologous recombinant deficiency, and that is one looks at the effect of this homologous recombinant deficiency, the pattern of genomic damage in the various in the somatic cells, in the tumor cells, and this pattern of genomic damage is what is we look for genomic instability tests, which may include the loss of heterozygosity or telomeric allelic imbalance or last case state transitions. So the all of these may indicate that there is genomic instability, and indirectly may indicate that the patient is having functionally the patient are homologous recombinant deficient, and maybe these are the patients which are candidate for PARP inhibition. So how genomic instability testing has the potential to identify much more women than simple BRCA mutation alone. So this is some of the data that we have. So germline BRCA mutation seems to be present in approximately 10 to 15% of high-grade epithelial ovarian cancers. Somatic is seen in another 5%, approximately 20% of high-grade ovarian cancer. And another 30% of these patients will have, apart from BRCA mutation, may have non-BRCA mutated, but they can still be HRR mutated or HR deficient. So assessing the genomic instability adds on is being found in approximately 50% of high-grade ovarian cancers and remains a potential target. So we have these tests being incorporated at various levels of evidence by various guidelines also now. So these are in the recent ESMO guidelines, which do recommend HRD testing to identify the patients which are most likely to gain benefit from a PARP inhibitor. So it is not only the germline or somatic BRCA mutation patients where we do have level 1 evidence and good clinical validity to the who benefit from these PARP inhibitors, but it can also be seen in the HR genomic scar assays, which look for genomic instability. So this is the opportunity which can identify those subgroup of BRCA wild type high-grade ovarian cancers who are likely to benefit from PARP inhibitors, which who may not be identified by simple BRCA testing or BRCA mutation testing. So what are the clinically validated methods to detect homologous recombinant deficiency in a case of ovarian cancer, high-grade ovarian cancer? So this is either we test somatic BRCA mutation. Yes, we can do germline BRCA mutation also, but somatic will pick up in another 5%. And the debate still continues whether germline first or somatic first. But yes, if tumor tissues are available, then somatic makes sense. One is you test for the BRCA mutation. The other is you can also test for genomic instability in this tumor tissue, which will further enhance your pickup of not even the wild type BRCA tumors, which may still be HR deficient, and this can be through the various markers of LOH or telomeric imbalance or large scale state transitions, which are generally part of this genomic instability test. And one of the frequently available tests is the Myriad My Choice genomic instability test, which was actually used in the Paula phase 3 trial. So whenever the consideration is being taken for the first line maintenance therapy in clinical practice in high grade ovarian cancers, serous ovarian cancers, one is definitely whether the patient is BRCA mutated or wild type. But now after Paolo, I think the data is enough for us to incorporate even HRD positive, HR deficient or proficient tumors should also help us in making decision. Another important step is always, yes, whether bevacizumab has been the part of chemo or bevacizumab is contraindicated. That is also one an important thing, whether we want to continue bevacizumab or not. And yes, definitely another important point is the stage of the tumor, the neoadjuvant chemotherapy versus surgery upfront, the residual tumor. Platinum sensitivity is another marker beyond HRD status that may help us in guiding further, and not to forget the expected toxicity. And when we talk of toxicity, we are definitely not talking of just physical toxicity. Financial toxicity is also something that we need to consider in our group of patients. So we have enough data about olaparib maintenance in ovarian cancer, in the newly diagnosed ovarian cancer, in the first line maintenance. And then we know that this data comes from two large phase 3 trials. One was the solo trial, that was where the inclusion criteria, the inclusion population was BRCA mutated. So all newly diagnosed advanced ovarian cancers, irrespective of the surgical outcome, but BRCA mutated population where the patients underwent surgery either upfront or midway and chemotherapy and were continued with olaparib maintenance versus placebo. And the other is, of course, the Paolo trial, where apart from the categorization, so in this it was more of I would say more like the population was a clinical practice population, because it was not only BRCA mutated, it included both BRCA mutated and non-mutated tumor, and it included both HRD positive and HRD negative patient. Then again, irrespective of the surgical outcome, irrespective of, and here the patient's inclusion criteria also included bevacizumab, where there was a comparator arm with placebo with bevacizumab, and the other arm was olaparib plus bevacizumab maintenance. So the solo 1 trial we already have discussed. The inclusion was basically BRCA mutated, either germline or somatic, and we had olaparib versus placebo. And the primary endpoint was progression-free survival, and yes, the secondary endpoint was again progression-free survival by the blinded independent review committee, PFS to overall survival, and time from randomization to first subsequent therapy, and also quality of life issues. And the PFS advantage, what we all in the oncology community are very much amazed, were very much influenced by this trial, because the PFS advantage which we found in these BRCA mutated tumors, something that we not very commonly seen in our cases. So there was a hazards ratio was 0.33, approximately 60 to 70% of the patients benefited, and the PFS in the BRCA mutated cases was 56 months versus 13.8 months. And what is also important is, as per the trial design, the patients received maintenance, olaparib maintenance for 2 years, but the benefits, we can see that the curves, they remained separated even beyond that. So it is not that once you stop therapy, the curves started merging. The curves remained widely separated even beyond that. And at follow-up for approximately 4 to 5 years, the curves remain widely separated. So this is something which is very encouraging. And olaparib was found to reduce the risk of progression or death to the tune of approximately 67 to 70%. And not only that, it had a significant difference in the second progression-free survival, irrespective of the second-line therapy, and the time to second-line therapy or subsequent therapy at relapse. So,
you have
any
about 2
drug
minutes left.
Yeah, I'll come to the side effects later then. So Paolo was, I'll just try to shorten. So Paolo was a step ahead or from Solo, because already, as I mentioned, it was not only BRCA mutated, it was more like a real life where you had unselected by biomarker status, and you had further subgroups, and this was the phase 3 study which had an active comparator arm also, where bevacizumab was given in the comparator arm, and again the results were were beautifully almost double that was seen in the comparator arm. And looking at the forest plot, again we can see that the arm, irrespective of the age, irrespective of the FIGO stage, or the surgical outcomes, or the timing of cytoreductive surgery, and irrespective of the response to chemotherapy, as long as the patient was responding, the graphs, the figures were largely in favor of olaparib plus bevacizumab maintenance. And hence we see that till Solo, if Solo is applied, then it is only a small BRCA mutated population where we see that they can benefit from PARP inhibitors. But going beyond BRCA mutated, even the BRCA wild type, if genomic instability score is applied, there is almost 50% of the patients who become eligible for these PARP inhibitors, and the result seems to be replicated not only for the first PFS, but even PFS1 and PFS2, and the result seems to be beyond the study trial also. Again, what we learned from Solo, that it is beyond the initial maintenance therapy only. So what we are talking of is a group beyond BRCA mutation and HRD positive group, which is actually means that combining the two groups, we talk about almost 50% of the population. So again, something which I have already said, I will not want to, because of lack of time, whether it was high risk disease or low risk disease, irrespective of stage 3, stage 4, the benefits were seen. The only group where the benefit was not seen was the HRD negative group. So HRD positive and BRCA mutated, and in the intent to treat population, yes, the benefit of the combination maintenance was much more than bevacizumab alone. And again, the side effects between the two arms were not markedly different. The side effects, we know that PARP inhibitors, the main side effects are fatigue, anemia, and the most dreaded side effect, or rather I will say the side effects of special interest for all of us oncologists, MDS AML, which we were so worried about, was seen only in 1.1% of the cases, and at the final PFS, that is at 3 years. So the figure did not change. So it was not cumulative. So even at 3 years, it was only the same number of patients who had MDS, and which is a small minuscule, just 1% of the cases. Yes, pneumonitis is something which can be seen with all these PARP inhibitors, but again, it is approximately just 1% of the cases. And quality of life was was quite maintained with these PARP inhibitors compared to placebo versus compared to bevacizumab maintenance. So this is my final slide. What are the takeaway messages? So it is not only BRCA testing, it is probably something beyond BRCA testing that we need to look at, and HRD scar test can be something. So we can either go for the genomic assays to look for these BRCA-like mutations, or we can, better is still, a genomic instability test that talks about the effect of these tests, and it can predict, and with this we can probably, it may be approximately 48 to 50%, a much higher percentage of these patients who may have response to PARP inhibitor in the first line maintenance. There's enough data from Solo and there is enough data from Paolo. So Solo was BRCA mutated and Paolo was HRD positive patient, and a significant improvement in PFS with this combination. And the mainly was that it is again, the take home is it is not only BRCA mutated, even among the BRCA wild type, the HRD deficient tumors, the benefits of PARP are no less. And this is something that should, all attempts should be made to identify this subgroup of patients also. And with that, I say thank you. Thank you.
Thank you, madam. I think that was a very precise and a sharp presentation. I think we couldn't have asked for a better conclusion to the gynecology session, where we are moving towards more and more targeted therapy and better outcomes. With this, I thank Dr. Meenu Walia madam for joining with us, and I now request Dr. Ruchi Singh to please start the MSK and the neuro session, please. Dr. Ruchi, please. Okay, so may I invite Dr. Nidhi Patni? Nidhi Patni ma'am is a radiation oncologist at Jaipur. To please invite the first speaker, Dr. Nidhi ma'am.
Yeah, I'm here. Good evening.
Thank
May
you,
I
Dr.
invite
Nidhi.
Dr. Sayan Paul to speak on the year in nutshell in neuro-oncology. It is going to be a wonderful session, I'm sure of that.
Am I audible?
Yes,
you're audible.
Yeah. Can I share my screen?
Yes.
Please do so.
Yeah, sure. Thank you.
3 months के बाद सारी रिपोर्ट कर ली, अभी अल्ट्रासाउंड नहीं था तो वो करके दिखाने के लिए बोला.
Yeah. So can you see my slides now?
They are visible. They are visible,
Yeah.
Dr. Sayan.
Okay, thank you. So good evening all. Thank you organizers for inviting me for giving this talk today. So
hold on. May I request everyone in the audience to please mute their mic?
okay. So can I start?
Yes, please go ahead.
Yeah. So so I was asked to discuss about some important articles that was published in 2021. So before starting, I must say that I have searched extensively, but not very extensively. So these articles are important articles, but these may not be the most important articles. And because I have only 10 minutes time, so I'll try to give a brief idea about each trials and each articles, but I will not be able to thoroughly discuss each of them. So the first one is an epidemiology study, that is the brain and other central nervous system tumor statistics, that was in 2021. So they have published the epidemiological data. So it is from the NCI's SEER data and the Center for Disease Control and Prevention's data, National Program of Cancer Registries, and combined with the Central Brain Tumor Registry of the United States. So this is a population-based registry system which focuses exclusively on primary brain and other CNS tumors. So this data is from the United States, but it will give us a fair idea about the various type of brain tumors that we are seeing and their incidences, and mostly which are more common and which are less common, and how we are doing in terms of treating these tumors. So first of all, among the brain tumors, so non-malignants are around 70% and the malignants are around 30%. And among the malignant brain tumors, the most common is the GBM or glioblastoma, and then other gliomas and diffuse or anaplastic astrocytomas. Whereas a small number of brain tumors are meningeal tumors and lymphomas, hematopoietic neoplasms, and other malignant tumors. Among the non-malignant one, the most common one is the meningioma, then the pituitary tumor, nerve sheath tumors, and other types of brain tumors. So this is the distribution in males and in females. As you can see, in malignant tumors, it is more common in males and than the females, whereas the non-malignant tumors, they are more common in females than the males. And if we consider among the GBM, so GBM is actually more common in males than the females, whereas other non-malignant tumors are more common in females. This is age-specific rate per 100,000 population. So this is a 5-year relative survival data for different types of tumors. For malignant tumors, as you can see, so the best result is among the 15 to 19 years or 20 to 39 years of age group. And as the age increases, the survival also decreases. And as you can see, the GBM bars, they are very small, whereas the low-grade gliomas and oligodendrogliomas, the 5-year relative survival rate is quite encouraging. In non-malignant tumors, it is quite good, and most of them are between 80 to 90%, or even 100%. Like the nerve sheath tumors is all 99%, and meningioma, the relative survival is also very, very encouraging. So now, how these tumors, are they increasing in rates, incidence rates, or are they decreasing? Actually, most of the tumors are decreasing. Only the childhood and adolescent tumors are increasing. But the in other age groups, it is actually decreasing. And it is decreasing in non-Hispanic whites or non-Hispanic blacks, decreasing in Hispanics and Asian and Pacific Islanders. It's also decreasing. And for American Indians or Alaskan natives also, it is decreasing. This is the 10-year average annual percentage of change. Okay. So this is the 5-year and 3-year relative survival of malignant brain and other central nervous tumor, CNS tumors, combined and glioblastoma. So as you can see, for all brain and other CNS tumor, there is a slight improvement. And the improvement was most pronounced from 1995 to 2005. And for GBM, it remained almost flat in 1995. Then it improved between 95 to 2005. And then again, it is almost maintaining, it is becoming a little flat. We have not achieved very good improvement in glioblastoma survival. So this is according to the location of the tumors. So mostly it is frontal and temporal lobe tumors. And for oligodendroglioma, it is mostly frontal, then temporal. For diffuse anaplastic gliomas, it is frontal or temporal and parietal mostly. And for GBM also, it is frontal and temporal lobes. Now, so which type of tumor is actually increasing the incidence and which type of tumor are decreasing? So as we can see, so the anaplastic astrocytoma is a bit increasing, whereas anaplastic oligodendroglioma is also increasing, and malignant gliomas are a slight increase. Neuronal and mixed neuronal glial tumors also has increased. Tumors of the pineal region has also increased, and some mesenchymal tumors has increased in incidence rate, whereas all other tumors actually has decreased over the last 10-year period. So this is the incidence rate of malignant gliomas by the age. As you can see, the GBM incidence has actually increased a lot, and other tumors has not increased that much, but in GBM has increased above 65 years significantly, almost 13.3%. So they concluded that malignant brain tumor incidence rates declined by 0.8% annually from 2008 to 2017 for all ages combined, but increased 0.5 to 0.7% per year among children and adolescents. Malignant brain tumor incidence is highest in males and non-Hispanic white individuals, whereas the rates for non-malignant tumors are highest in females and non-Hispanic Black individuals. 5-year relative survival for all malignant brain tumor combined increased between 1975 to 1977 and 2009 to 2015 from 23% to 36%, not very encouraging, with larger gains among younger age groups. Less improvement among older age groups largely reflects a higher burden of GBM, for which there have been few major advances in prevention, early detection, and treatment in the past 4 decades. Especially 5-year glioblastoma survival only increased from 4% to 7% during the same period. So it is a very little improvement. So let's see what people are doing to improve the survival of GBM. So this is another trial published in IGROBP. It's a phase 2 study actually. So what they did is if they used biologically based target volume definition for patient in newly diagnosed GBM, and they tried to escalate the dose. So the hypothesis was to dose intensified chemoradiation therapy targeting adversely prognostic hypercellular and hyperperfused tumor volumes to improve, just to see how if it improves the outcome in patients with GBM. So what they did is in patients where there is hypercellular or hypervascular area is more than 1 cubic centimeter, they identified using the high B value diffusion weighted magnetic resonance imaging and dynamic contrast enhanced perfusion MRI, and they have treated to up to 75 gray in 30 fraction to these areas, and then they tried to see how it impacts the overall survival and also the quality of life. So this is the data. As you can see, the pre-radiation enhancing tumor volume was 16.9%, and after 3 months, it has decreased to 10.3%. And hypercellular volume and hyperperfused volume also decreased significantly. And all the volumes, all the enhancing area and combined hypercellular hypervascular area also has decreased in 3 months' time after the radiation. And the change is quite significant. And this is actually the survival data which we were interested in. So median follow-up time was 26 months, and patients treated to the combined hypercellular hyperperfused tumor volume had significantly improved 12 months overall survival, 92%. So compared with historical control, and the p-value is also significant. The median overall survival of this cohort was 20 months, and the median progression-free survival was 12 months. Among all 23 patients, the median overall survival was 20 months. So they concluded that dose intensification against hypercellular hyperperfused tumor region in glioblastoma yields promising overall survival with favorable outcome for neurocognitive function, symptom burden, and quality of life, particularly among patients with greater tumor reduction 3 months after radiation therapy. So this can be a little bit intriguing because this is one dose intensification data I could found in GBM. So this is a trial published from India. I wanted to keep one trial from India, from Tata Memorial Hospital. And this is a prospective longitudinal assessment of quality of life and activities of daily living as patient-reported outcome measures in recurrent and progressive glioma treated with high-dose salvage re-irradiation. So these are all re-irradiation cases treated at least 2 years back with full dose of radiation, and they recurred. These are all glioma patients who recurred after 2 years of the initial treatment. And they calculated the EQD2 of the previous treatment, and they have given a high dose as a salvage radiation. So the dose depended on the previous EQD2 and the calculation. So it was around 54 to 60 days, that what I could find in the paper they have given. And they tried to see how these patients are doing in terms of the quality of life. And as you can see, the physical performance, emotional performance, cognitive performance, and social functioning, everything improved over time. And they did follow up after 1 month, 3 months, 6 months, 9 months, and 12 months. So everything improved over time. And all the symptoms like fatigue, the loss of appetite, constipation, so all decreased over time, and both are significant. So they concluded that High-dose radiation in carefully selected patients with recurrent or progressive glioma is associated with stable quality of life, preserved functional domain, and reduced symptom burden, and improvement in ADL, greater functional independence, over a 1-year time period, with encouraging survival outcomes, supporting its use as an important component of multimodality salvage therapy. So this is quite helpful for us who nowadays are seeing more and more recurrent cases and patients are coming for irradiation. So the next one is the CATNON trial we all were waiting for. So this is adjuvant and concurrent temozolomide for 1p19q non-correlated anaplastic gliomas. So this is a large trial, a phase 3 trial from 137 institutes across Australia, Europe, and North America, include patients aged 18 years or older for 1p19q non-correlated anaplastic gliomas and with a WHO performance status of 0 to 2. So patients are randomly assigned 1:1:1:1 using minimization technique to radiotherapy. One arm was radiotherapy alone, and then radiotherapy with concurrent oral temozolomide, radiotherapy with adjuvant oral temozolomide, and radiotherapy with both concurrent and adjuvant temozolomide. So they try to investigate the addition of concurrent, adjuvant, and both concurrent and adjuvant temozolomide to radiotherapy in adults with newly diagnosed 1p19q non-correlated anaplastic gliomas. So the benefit of concurrent temozolomide chemotherapy and relevance of mutation in IDH1 and IDH2 genes remains unclear because they started before we got the classification. So there are 751 patients, a large number of patients, and almost 189, 186, 188, and 188 patients in all the 4 arms. And let us see what they found. So concurrent temozolomide versus no concurrent temozolomide, actually there was no benefit using concurrent temozolomide, but using temozolomide adjuvantly, it benefits. Adjuvant temozolomide is statistically significant compared to the arm which has no adjuvant temozolomide. And this is overall survival for IDH1 and IDH2 wild type tumors. So this was regardless of, first one was regardless of IDH1 and IDH2 mutation status, and this was for IDH1 and IDH2 wild type. But surprisingly, for IDH1 and IDH2 wild type, both concurrent temozolomide or adjuvant temozolomide, none of them helped. Both are statistically non-significant. Either you use it concurrently or adjuvantly. Then this one is for IDH1 and IDH2 mutant tumor. For IDH1 and IDH2 mutant tumor, concurrent didn't help, but the adjuvant helped. So they conclude that the benefit from temozolomide in anaplastic astrocytoma is derived from the adjuvant phase of the treatment, and it observed only in patients with IDH1 and IDH2 mutant tumors. Longer follow-up is needed, especially in IDH1 and IDH2 mutant tumor, as the increase in progression-free survival could in time translate into an overall survival benefit. So further studies are ongoing to assess molecular factor associated with prognosis. So from the CATNON trial, we could conclude that it is helpful if we use temozolomide adjuvantly in anaplastic astrocytomas, that too in IDH1 and IDH2 mutant tumors. So this one is actually a spinal case of spine, because all other includes cases of brain. So this is a stereotactic body radiotherapy versus conventional external beam radiotherapy in patient with painful spinal metastases. So this is from Dr. Arjun Saigal's team. So among the 229 patients, 115 patients they assigned for external beam radiotherapy, and 114 patients they assigned for SBRT. SBRT was 12 gray in 2 fractions, whereas EBRT was 20 gray in 5 fractions. And they have shown that the complete response rate and the pain response, that is progressive pain in the EBRT group, was 12%, whereas in SBRT group it was less as 8%. And after 3 months also the benefit remains, complete response benefit remains. And after 6 months also the same benefit remains. and the side effects were all comparable, were not more in SBRT arm. And they concluded that this trial suggests that SBRT at a dose of 20 gray in 2 fraction is superior to conventional external beam radiotherapy at a dose of 20 gray in 5 fraction in achieving complete pain relief at the radiation study target vertebral segment. This is all for vertebral segment volume site. So there are 2 more trials. This are the data we should discuss, and I think Dr. Dodul Mondal will be discussing all these 2. I'm just mentioning the names. One is the 2021 WHO classification of tumor of the central nervous systems and how what is the implication in our clinics. And the second one is a children oncology group phase 3 trial of reduced dose and reduced volume radiotherapy with chemotherapy for newly diagnosed average risk medulloblastoma. So this is also a huge number of patients who are included, 464 eligible patients. So what they did is they tested 2 things. One is IFRT or posterior foci radiation or a reduced volume, that is involved field radiation. And the CSI dose also they have reduced. One is the standard dose CSI, that is 23.4 gray, and the lower dose of CSI, that is 18 gray. Dr. Dodul will be discussing in details of this paper. So the conclusion was that the reducing the radiation boost volume in average risk medulloblastoma is safe and does not compromise survival, but reducing CSI dose in young children with average risk medulloblastoma results in inferior outcome, possibly in a subgroup dependent manner, but is associated with better neurocognitive outcome. So molecularly informed patient selection warrant further exploration for children with medulloblastoma to be considered for late effects hearing approach. So these are some articles I have discussed, and among these 2 articles will be discussed thoroughly by Dr. Dodul Mondal. One is this one, and another is the WHO classification thing. So thank you all. I want to thank Dr. Ritika Hinduja who has helped me to find out the articles and suggested few articles in this presentation also, and my daughter Tanishi for coloring the slides. Thank you. Thank you very much.
Thank you so much, Dr. Sayan. I think it was a really informative compilation of the whole year publications. Now I want to call our next speaker for the next session, and that is Ear in Nutshell. In musculoskeletal, Trinanjan is consultant radiation oncology in HCG Cancer Center, Mumbai. Over to you, Dr. Trinanjan.
Hi, good evening. Am I audible?
Yes, Dr. Trinanjan.
Okay, I'll just share the slides.
Yes, you are audible. Yeah.
Okay. Hi, Ruchi. At the outset, thanks to the organizers and Dr. Ashu. So I have been given the role to discuss important publications in musculoskeletal oncology. This is a rare topic. So just few background introductory information. We know sarcomas are a heterogeneous group. There can be bone and soft tissue sarcomas. They're rare as well and have varied presentations, different biologies, different course of treatment, as well as different outcomes. Most of the cases, surgery remains the mainstay, and radiation and chemo comes in different scenarios, either together or in sequence. The extremity sarcomas remain the most common sites, and just for the sake of completion, I've put this AJCC classification. So how we're going to discuss. So I have tried and searched among the staging, classification, and molecular subtype related articles based on surgical technique, medical oncology, as well as radiation oncology. Since it's a rare topic, so I have chosen articles between 2020 and 2021 with national and international journals of repute. There's a blend of diagnostics, both histopath and imaging based, multidisciplinary team approach articles, and consensus guidelines. weightage been given to randomized control trial and systemic review meta-analysis, and few also large retrospective series, since they are a bit rare tumors. So this to just to reiterate the importance of multidisciplinary team approach in sarcomas, and actually people have done publications related to that, whether an MDT approach was carried out and how the survival, and once it is not carried out. And this nice review in this year in BMC musculoskeletal disorders, people can read in detail about the newer developments of musculoskeletal oncology. So the flow would be, we'll try and see diagnosis and modern histopath related publications in last 1.5 years. Then the pre-surgery neoadjuvant treatment related publications, how the response can be predicted by modern radiomics, then consensus guidelines for multidisciplinary team management, the recurrent metastatic disease and chemotherapy related trials, few consensus guidelines from different societies dealing with musculoskeletal oncology, and of course, in today's time and era, nothing goes without mentioning COVID-19 and sarcoma guidelines. So the first and most important is to see the 2020 WHO classification for tumors of soft tissue. They have included few new entities and deleted few. So this is the 5th edition of WHO classification of bone and soft tissue tumors. Besides morphology, the genetic, the moleculars, the IHC-based markers and biological mechanisms are also incorporated. There are total 11 subcategories with new addition of undifferentiated small round cell sarcomas on bone and soft tissue. And this is an exhaustive list, so one has to see that in detail. And this is the basic changes from 2013 classification. Few have been renamed and removed, and few of the tumors have been removed totally in the 2020 classification. In lieu with this, there's a separate also article in Seminars in Diagnostic Pathology this year on the Ewing sarcoma important changes. So it actually follows the 2020 WHO classification with new distinct entities like round cell sarcomas with EWSR1 non-ETS fusion genes Ewings, CIC rearranged sarcomas, and sarcomas with BCOR genetic alterations. This tongue twisting mutations and other details actually have to read separately. There's a Hugo gene nomenclature committee which actually decides and renames and reclassifies these tumors. So this is what should be the schema as given from this pathology article. Any small round blue cell tumor in morphology based on the IHC, how they are classified between a sarcoma and non-sarcoma, and what all FISH or NGS based diagnosis should be carried out. These are the different IHC markers which are utilized in this, and the diagnostically useful gene fusions in round cell sarcomas. So after the diagnostic part, let us see few surgery and related important publications in MSK oncology. So though the first one, this one is a single center 30 years experience of retroperitoneal sarcomas. This was done in Helsinki over a 30 years data of a single institute. Though the patient number is quite less, only 107 patients. The important to see between the disease-free survival and the metastasis-free survival, that whether radiation was given pre-operatively or post-operatively, it resulted in worser DFS and MFS. But nice to know in the publication also that authors have quoted, this is probably a patient selection bias because their institution treatment protocol reserves pre-op RT for grade 2 or higher tumors to increase the likelihood of radical resection, and post-op RT for high-grade tumors that have been resected intralesionally or with a narrow tumor-free margin. So probably that's a reason. So why I have highlighted that? Because the next one would be in line of these pre-op treatments. So since we're radiation oncologists, there are now data of hypofractionated radiotherapy. This one is a Green Journal publication of neoadjuvant hypofractionated radiotherapy and chemotherapy for extremity soft tissue sarcomas. It's a phase 2 feasibility study for extremity soft tissue sarcomas, giving neoadjuvant chemo with adriamycin and IFOS into 3 cycles and 25/5 fractions of radiation with primary endpoint of disease-free survivals. They also looked into wound complications, pathologic response, and mortality. Very few patients, only 18, with local control of 95% and 33% PAT-CR, which is quite encouraging, but limited by small sample size. The next one step further of doing neoadjuvant SABR actually is SBRT for soft tissue sarcomas of extremities, published also in Green Journal this year. So since it is SBRT, not only in 5x5, so the dose has increased to 40x5. And as per the prelim data, this is quite safe and a good PCR rates. But we definitely have to wait for further long-term data. Now, in the same line for the neoadjuvant treatment, there's a PASENTES trial, which is a children oncology group and NRG joint collaboration for unresected trunk and extremity soft tissue sarcomas, which are more than 5 centimeter, intermediate to high grade, and they've selected chemosensitive subtypes. So what they have done, they have given a pre-op radiotherapy of 45 day with Adria and IFOS-based chemo, and the same regime with pasopanic with 2 different doses depending on 18 years less or more than 18 years. And the surgery would be at week 13. And what they have found that more than 90% of PAT-CR was seen by adding pasopanic in 58% of the patients, whereas only 23% with the standard treatment, with no additional serious adverse events. So it's a positive trial across all ages for pasopanic in the neoadjuvant setting. Then we all know the often highlighted and criticized for pre-op RT STRAS trial. I will not go into the STRAS trial details because Dr. Shikha will be discussing this in her presentation. So in the same line, something to do with limb salvage versus amputation for osteosarcoma. This is a National Cancer Database publication of more than 2,000 high-grade osteosarcomas of extremities between 2004 to 2015. They have analyzed demographic as well as clinico-pathological features and did a propensity score match analysis. And they have concluded with large tumors, those were advanced age, poor socioeconomic status, and less access to healthcare actually undergo amputation. Whereas there's a trend towards improved survival by doing limb salvage. So this trial also highlights the importance of completing the chemotherapy for osteosarcomas. In the same line now, switching the gears to GIST in gastrointestinal stromal tumors. So this is an JAMA Oncology publication for Scandinavian Sarcoma Group. It was a 2020 ASCO podium presentation for multicentric phase 3 trial, 1:1 randomization, close to 400 patients and 10 years follow-up. And the high-risk GIST received either 1 year of adjuvant imatinib or 3 years of adjuvant imatinib for the post-microscopic complete resection. The high-risk categorization was by NIH consensus statement, and this actually concluded that 3 years of adjuvant imatinib has superior efficacy compared to 1 year, and that should remain standard of care. Now, in the same line, the international intergroup randomized trial for adjuvant imatinib, and they tried to look also into quality of surgery and outcome. So the main issue is what is the association between quality of surgery and overall survival in patients who have localized intermediate to high risk GIST, and whether R0 or R1 resection matters. So this is basically a post-hoc observational analysis with a median follow-up close to 10 years and randomization after surgery between adjuvant imatinib or no treatment, with overall survival as primary endpoint. So 900 plus patient randomization by center treating, risk category, tumor site, and quality of surgery. So the difference in overall survival by quality of surgery with or without imatinib was associated with presence of tumor rupture. So the tumor rupture remains the important factor, not alone R1 margin with worse overall survival. So the tumor rupture remains the most significant factor. So then in neoadjuvant chemotherapy, this is a final result of randomized trial from 4 European sarcoma groups from Italy, Spain, France, and Poland. It was published in JCO. This is a randomized phase 3 trial. What they have done for localized high-risk soft tissue sarcomas, more than 5 centimeter and grade 3 for trunk and extremities, they have selected 5 subtypes of myxoid liposarcoma, leiomyosarcoma, synovial, malignant peripheral nerve sheath tumors, and undifferentiated pleomorphics. 1:1 randomization between standard IFOS doxo-based chemo, or they have quoted something called highly tailored chemo, so which is histology based, and they have done different chemo regimes for different subtypes with the primary endpoint of DFS between standard chemo or highly tailored chemo. So 287 patients, median follow for 52 months. There were no difference in either arm for DFS or OF, as you can see in the Kaplan-Meier survival curve as well. However, there were no treatment-related death. So this trial actually has concluded if neoadjuvant chemotherapy are to be selected, then still standard IFOS doxobase chemo can remain as standard of care. The next one, once the neoadjuvant treatment is given, and in today's time and era, radiomics remains an important. That's why I've chosen this European Radiologist Systematic Review for Radiomics in Osteosarcoma. It has selected 12 studies and finally included 5 in their meta-analysis. The data is emerging, more and more data will come out. It has a very interesting role after the neoadjuvant chemo in osteosarcoma in predicting response by radiomics. So now, based on few of the society guidelines, and they are the ESMO European Gentures guideline. They have given very nice guideline published related to the bone sarcomas, related to GIST, and related to soft tissue and visceral sarcomas. The detail of them can be read separately. This is to highlight since they are consensus guideline and has important value. Now, moving to radiation related in last 1 year, the important one which is published in PRO for the ASTRO executive summary for the radiation treatment of soft tissue sarcomas. Like other summaries, they've given radiation for.
I think we are running short of time, so please be a little bit quick.
Yeah. So the ASTRO summary is on primary localized operable soft tissue sarcomas. They highlight 5 key questions like they do of role of radiation in different sequencing, dose fractionation, target volume, target delineation, pre or post-op radiation. Similarly, this is an Indian data and should be highlighted from TMH for dose escalated image-guided intensity modulated treatment for osteo, chondro, and chordoma. So we know we require a dose more than 70 gray for curative. Nothing goes without highlighting the brachy for sarcoma. This is an Italian Association Sarcoma Conference consensus guideline, and they've given very nicely these points which are exhaustive for brachytherapy in sarcoma. Now, just I'll touch upon, since there's a paucity of time, on 2 recurrent metastatic. One is a SARC 024 study, which is a regorafenib versus placebo study, and it's a negative study for regorafenib. The study did not find any significant difference. Whereas the other one is a TSAR data on best supportive care versus trabectedin, which actually has shown a good median PFS with trabectedin with no increase in serious adverse events. So it's a positive trial for trabectedin. And in today's time and era, nothing goes without highlighting COVID-19 and sarcoma. This is a European and Latin American consensus statement called CellNet for sarcoma treatment categorization and prioritization during COVID. So there are 125 questions and recommendations related to this. So one can go through in their time. So I'll sum up. Thank you.
Thank you. Thank you so much, Dr. Thunaranjan. It was really informative compilation. I think everything was covered in this session. Now let's come to the next session, and that is publication in neuromuscular skeleton oncology. I want to invite Dr. Shikha Goyal, ma'am. Ma'am is assistant professor in PGI Chandigarh. Over to you, ma'am.
Thank you, Ruchi. I'll be discussing the STRAS trial that came last year in Lancet Oncology. So it's a trial on preoperative radiotherapy plus surgery versus surgery alone for patients with primary retroperitoneal sarcoma. It's a randomized phase 3 multi-center trial. So there were 31 institutions in Europe, Canada, and USA which participated in the trial. And the patients who were eligible were those more than 18 years with a good performance status, an ASA score of less than or equal to 2, normal renal, liver, marrow, and cardiac function, with a localized primary soft tissue sarcoma limited to either the retroperitoneal region or intraperitoneal lesion within the pelvis, histologically proven just 1 lesion, non-metastatic, and the tumor had to be suitable for radiotherapy, and the patient should have been operable by all criteria. Patient should not have received any prior therapy, and there was no coexisting malignancy within the last 5 years except for basal cell carcinoma or carcinoma cervix. They mandated that imaging should have been done within 4 weeks of randomization, and there was radiologically measurable disease, and there were no complications such as bowel obstruction, mesenteric ischemia, or severe chronic inflammatory bowel disease, and there were no factors which would compromise compliance. So if the patient had, there was an anticipation of R2 resection on the baseline CT scan, these patients were excluded. Several histologic types were also excluded. These were just rhabdomyosarcoma, PNET, osteosarcoma, chondrosarcoma, any aggressive fibromatosis, sarcoidoid carcinoma, or metastatic disease. So the randomization was 1:1, and the patients were stratified by hospital as well as performance status. Since there were 2 arms, if the surgery alone arm was chosen for the patient underwent on-block curative intent surgery, either R0 or R1, within 4 weeks of randomization. And if it was the RT arm, then the patients would receive radiotherapy and then undergo similar surgery within 4 to 8 weeks of completing radiotherapy. Most patients received radiotherapy by IMRT. There was a very stringent quality assurance mandated by EORTC. Radiotherapy had started within 8 weeks of randomization to a dose of 50.4 gray in 28 fractions. The gross disease was seen as seen on CT with or without additional images was marked as GTV. There was a 5 to 6 millimeter expansion around this given to generate the CTV. And the PTV was not based on any motion management technique. 9 millimeter medial and anterior margin was given to the CTV and 12 millimeter in other directions. And there was a need that at least 95% of the planning target volume should receive 95% of the prescription dose. So follow-up imaging was done in the defined interval, and adverse events were noted both for the post-op period as well as for future follow-ups by the CTCAE version 4. And if there was disease progression, diagnosis of a second malignancy, any unacceptable adverse events, then these patients withdrew from the study. Also, if the patient decided to withdraw at any time, or even after radiation, if the imaging done at 2 weeks post-RT had an anticipation of R2 resection, this was a criteria to withdraw. The trial had a very unique endpoint. The primary endpoint was abdominal recurrence-free survival. And this was defined by one of the following events. There was either a local or distant progression within the abdomen during preoperative radiotherapy. The disease or the patient became inoperable subsequently, either medical inoperability or poor resectability due to involvement of bone or vessels. If there were peritoneal metastasis found at surgery, if there was R2 resection, or if there was local relapse after a macroscopically complete resection. And there were several secondary endpoints, including tumor response, metastasis-free survival, overall survival safety, and QOL. So this trial randomized 266 patients into the 2 arms, 133 in either arm. In the surgery arm, out of the 133 patients, 128 had surgery. Subsequently, 4 were lost to follow-up. So only 124 completed the follow-up, but it was an intention to treat analysis. So all the patients who were randomized were included. In the pre-op radiotherapy arm, 119 had both treatments. Subsequently, 7 were lost to follow-up. So only 115 completed the follow-up, but all the patients randomized were included in the last analysis. So this is the breakup of demographics. Age was similarly distributed, so was gender. Most patients had performance status of 0 or 1, only 1 patient with PS2. And the most common histologic type was liposarcoma, which was nearly 75%, and nearly 15% were leiomyosarcomas. And most of the patients had low or intermediate grade at biopsy, but nearly 25% patients, the grade information was not known. So when all the patients were taken together, including all histologies, we saw that at a median follow-up of 43 months, there was virtually no difference between the 2 arms. The 3-year abdominal recurrence-free survival was 58% in the surgery arm and 60% in the radiotherapy arm. And if only the subgroup of liposarcoma was taken, the difference was nearly 10%. The RT arm performed better than the surgery alone arm with a hazard ratio of 0.62. So there were only 65% patients who completed therapy. There was compliance to treatment without any major violations. When we talk about the response in the radiotherapy arm, 77% patients had either stable disease or partial response. 14% had progressive disease, but of these, 80% still managed to undergo complete resection, and 8% patients were either not evaluable or had early deaths. When we talk about adverse events, lymphopenia was the most common grade 3, grade 4 adverse event in the radiotherapy arm, followed by anemia and low protein. There was one treatment-related death in the radiotherapy arm, whereas none in the surgery arm. So after all this, the study concluded that the preoperative radiotherapy cannot be considered as the standard of care for retroperitoneal sarcoma. So just coming to a brief discussion on the pros and cons of this trial, we know that in limb sarcomas, the combination of radiotherapy and surgery was explored as a means to limit surgical extent, as a means of limb salvage and to avoid amputation. And here it showed that when we attempt limb salvage surgery, if we omit radiotherapy, there was an increased risk of local relapse. The local relapse without RT in the earlier studies was nearly 24%, whereas with RT, it was less than 2%. But the overall survival had not shown improvement in the earlier studies. Overall survival benefit for radiotherapy in limb sarcomas was seen only in retrospective large data, and that too only for high-grade sarcomas. The randomized trial by O'Sullivan way back in 2002 had shown that preoperative radiotherapy was comparable to postoperative radiotherapy, both in terms of local control as well as overall survival. There was a recent systematic review which had shown that postoperative radiotherapy had overall survival advantage, but this also included a lot of retrospective data. We also know that for radiotherapy planning in limb sarcomas, the clinical target volume is typically a 3 centimeter expansion around the gross disease, and intensity modulation shows better normal tissue sparing with better conformity. Now coming to retroperitoneal sarcomas, they are a therapeutic challenge because of their size as well as location. There is a higher tendency for positive margins when going for upfront surgery. The rates of R1 or R2 resection are high to the tune of 60 to 90%. And the local recurrence rates are also high, reported in various series from 40 to 80%. And these recurrence rates increase when the follow-up duration increases. The uncontrolled local disease is the major cause of morbidity and mortality. And we know that these sarcomas are a heterogeneous group. Not all of them behave similarly. We have clubbed leiomyosarcomas, liposarcomas, undifferentiated sarcomas into one group, and we've tried to look at their behavior together. But we know that they have different prognosis. They have different recurrence patterns based on the type as well as grade. So the challenges with radiotherapy when we are performing it within the abdomen is that low doses give poor control because these are essentially radio-resistant or relatively radio-resistant tumors. High doses would give poor tolerance because we have a lot of viscera, including bowel in the abdomen, which would be exposed to these doses. So radiotherapy volumes cannot be liberal, and the sensitivity of various histologic types is also variable. Prior to STRAS, another attempt had been made to do a randomized trial, but it failed because of poor accrual. And an expert consensus panel had also formulated preoperative radiotherapy guidelines for retroperitoneal sarcomas, which came in 2015. There was a large analysis, retrospective again, published in 2016, which had shown a survival benefit in favor of radiotherapy, both preoperative or postoperative when compared to no radiotherapy. And all prior publications were eagerly awaiting the results of STRAS, since surgery alone had its challenges. The problem with the trial design is that the endpoint is unique, so there is no prior comparator, but the endpoint did not differentiate between local and regional progression. And it also clubbed technical and medical inoperability into one endpoint. Now we know that if a patient has a regional progression on radiotherapy, it is essentially an issue of selection, not an issue of radiation failure. So that was not possible to distinguish in this trial. Also, when the trial was planned, the relapse patterns and patterns of behavior of the histologic types were less well known. So the trial did not limit itself to a single pathology or a single dominant pathology. It makes better sense now to include liposarcomas and not leiomyosarcomas, since they are more radio responsive, and low-grade tumors are expected to benefit more. So the trial probably should have limited itself to lower grade tumors. In this particular trial, nearly 1/4 patients, we did not have any grading information. It would also have been possibly more fruitful to include borderline operable cases rather than clearly operable cases, considering more concern is there for margin positivity and relapse rates. So resectability or R0, R1 resection rates would have made a more sensible endpoint.
Sorry to interrupt you, ma'am. But we are running short of time.
Yeah, I'll just speed up. So the peritoneal disease is difficult to assess on imaging. So that also is a failure. With the radiotherapy volumes, the CTV margin of 5 to 6 millimeters is insufficient. And motion management and image guidance were also not addressed. And the dose also seems lower, because we have seen that in prior series where SIB and intraoperative radiotherapy have been used, the results have been better. Assessment at 2 weeks is also insufficient. And we do not have any information on adjuvant therapy given when R1 or R2 resection was achieved. To summarize, it's a laudable effort because a lot of institutions have come together for a rare malignancy. But the only conclusion we can draw from this trial is that for resectable retroperitoneal sarcomas in general, a dose of 50.4 gray with limited margins without motion management or image guidance is insufficient to reduce locoregional relapses. Although post-hack some benefit was seen for liposarcomas, surgery alone does not suffice. Hence, additional therapies will continue to be explored. And we know from head and neck neoadjuvant chemotherapy experience that any improvement in resectability will improve survival in that subgroup of patients. Future trials would focus on systemic therapy, again, histotype adapted, as well as use of hypofractionated or particle therapy based radiation to improve resectability rates and to improve survival in this group. And our radiomics and AI information may help us refine the patient selection and also define prognosis upfront. Thank you.
Hello.
Yes, ma'am. And kindly invite the new speaker.
Yes, am I audible?
Dr. Dodul Mandal, please.
Share my screen. Can you please allow me sharing my screen? Okay, is my screen visible? Am I audible?
Yes, you are.
Am I audible?
Yes, you are.
So good evening, everyone. And thank you, Jacinta ma'am, for giving me this opportunity. So as mentioned by my friend, Dr. Shayan, in his talk that I will be discussing one article. So actually, I will not be able to discuss both the articles. So I'm going to discuss this phase 3 study by the COG group, and I'll not discuss the updates in classification of brain tumors as mentioned by Dr. Sayan. So this is a children's oncology group phase 3 trial of reduced dose and reduced volume radiotherapy with chemotherapy known as ACNS 0331 study. Now, traditionally, as we know that medulloblastoma, the risk stratification defined into 2 different categories, standard and high risk tumors, depending on age and extent of residual tumor or presence of metastasis. So average risk becomes more than 3 years of age without any evidence of metastasis with less than 1.5 centimeter square in largest cross-sectional diameter. And high-risk tumors are either less than 3 years of age or anyone with more than 3 years of age with evidence of CSF spread, either M1 to M3 disease, and those with less than a complete resection, which is more than 1.5 centimeter square cross-sectional diameter. And later on, the molecular classification was added, and it was subdivided into 4 different groups like WNT, Sonic Hedgehog, Group 3, and Group 4. WNT pathways having the best outcome, and Group 3 having the worst outcome. Primary pattern of failure in WNT group was local or metastatic, which was the range. So main failure was local, and Group 3, Group 4 main failure was metastatic in nature. In recent classification 2021, WHO has also included all these molecular markers in classification of medulloblastoma, and now it has been divided classified into medulloblastoma WNT activated, Sonic Hedgehog activated, TP53 wild type or TP53 mutant, and non-WNT, non-Sonic Hedgehog pathway. And these are different mutations which are included in the classification system. Maximal safe resection with craniospinal irradiation remains the standard of care of now. Now, as the background of the study, traditionally the CSI dose is 23.4 gray, or the CSI or craniospinal irradiation dose is 23.4 gray to the entire neuroaxis with posterior fossa boost to a dose of 55.8 GY. This was 2006 JCO publication. However, with this approach, the problems were mainly with neurocognition, hearing loss, and multiple endocrine abnormalities. Different strategies were considered to reduce all those complications, like delaying radiation, reducing the radiation dose, following a hyperfractionated regime, and this is current approach or current thing which I'm going to discuss, reduced radiation boost volume without compromising disease control. So ACNS 0331 was a phase 3 study undertaken in patients with average risk medulloblastoma to determine if a reduction in radiation boost volume in all children and a reduction in CSI dose in younger children accompanied by chemotherapy, concurrent and adjuvant, whether it would maintain favorable outcomes and minimizing toxicity or not. So the salient patient selection criteria included kids with more than 3 years of age, having less than or maximum up to 1.5 centimeter square residual tumor in largest cross-sectional diameter, having a good organ function, performance status of more than equals to 50, previously untreated. And if someone is more interested to know all these in detail, I can share the article with them. So this was the treatment protocol. For age 3 to 7 years, there are 2 different randomization. One randomization based on whether it was entire posterior fossa boost or a reduced volume gross tumor and cavity boost. The second randomization was a standard dose CSI of 23.4 gray versus 18 gray low dose or reduced dose CSI. Now, after this 18 gray CSI randomized to this 18 gray CSI, another 5.4 gray dose was delivered to the posterior fossa for all children to make the entire posterior fossa dose 23.4 gray. That was followed by additional 30.6 gray to either the entire posterior fossa or to a reduced volume. Now, for the patients between 28 to 21 years of age, the dose for craniospinal irradiation was standard 23.4 gray, and in this age group, only one randomization happened, which was either a standard posterior fossa boost or a reduced volume posterior fossa boost. Concurrent vincristine was given weekly starting from week 2 for 6 doses, followed by adjuvant chemotherapy following 2 schedules, cycle A and cycle B, and I'm not going into the details of that. That is how the radiation was planned, the entire craniospinal axis, followed by a posterior fossa boost. And this is how the reduced volume posterior fossa boost was planned. The tumor cavity or any visible tumor or residual tumor seen on MRI with 1.5 centimeter margin all around as clinical target volume, followed by additional margin to generate the planning target volume. So that was the reduced volume arm, and this is the standard volume or the entire posterior fossa group, where the entire posterior fossa was contoured as clinical target volume, and additional margin was given to generate the PTV. It was recommended that the planning MRI be fused, and while contouring the posterior fossa, sagittal section should be visible to define the superior and inferior extent. Supratentorial brain, both sides, both cochlea, hypothalamus pituitary, both eyes, optic nerves, lens, optic chiasm, cervical spinal cord, these were contoured as the normal organ saturation. The study was non-inferiority in design, and event-free survival and overall survival were the main outcome to be looked at. EFS was calculated from the date of study entry to the date of disease progression, recurrence, occurrence of any second malignant neoplasm, or death from any reason. OS was calculated from the date of study entry to the date of death from any reason. And it was the study was designed to detect with a 94% power for both the arms to detect a 10% reduction in 5-year EFS and OS for reduced volume boost or for reduced dose CSI. Baseline characteristics or the demographic profile were similar in all age groups. Now, total 549 patients were enrolled and 464 patients were evaluable at the end. And among those 464 eligible evaluable patients, 5-year EFS and OS were 81.4% and 84.9% respectively. Now, when the outcome was different in terms of different treatments, it was that IRT or volume posterior fossa does not have an inferior outcome compared to the whole posterior fossa boost. The p-value was non-significant for both EFS and OS. However, when the dose of CSI was considered, it was seen that low dose CSI had an inferior outcome both in terms of EFS and the overall survival, and both were statistically significant. So low dose CSI was perhaps not a solution. Now, when the molecular subgroups were seen, it was found that WNT pathway is doing the best among all of them in terms of both EFS and overall survival. Group 3 was having the poorest outcome as expected. SHH and group 4 were coming in between. So that is what as per the expectation. Now, these molecular markers were again compared with different treatment groups. So when reduced volume posterior fossa boost and posterior fossa boost were compared between different molecular groups, it was seen that only Sonic-Hedgehog group has a difference in outcome, and surprisingly, it was seen that Sonic-Hedgehog group patients were having a poor outcome when they were treated with the entire posterior fossa boost. So you can see here. So perhaps for patients having a Sonic-Hedgehog, this SHH group, they would do better when they will be treated with reduced volume posterior fossa boost. Now, when the dose of CSI was compared between different molecular groups, it was found that only group 4 has a difference in outcome which was statistically significant, and low dose CSI was doing worse compared to standard dose CSI. So going by the molecular classification, we can see that for group 4 patients, standard dose CSI should be the solution. And for Schoenig-Heger group, the reduced volume boost should be the solution. When the pattern of failure was compared between different molecular subgroups, it was seen that the WNT pathway had only a local failure pattern. Group 3 and group 4 had significant local and distant failure as well. Schoenig-Heger came something in between, having mostly a local failure, but associated with distant failure as well. Now, when looking at the neurocognitive part, it was seen that the children aged 3 to 7 years, their IQ was much better when they were treated with low
Dr.
dose
Morgan, you have 2 minutes to wind up. 2 more minutes to go.
Yeah. Yes. There was no difference in processing speed. However, when the reduced boost volume and whole posterior boost volume was compared, the IFRT was
sorry to
doing
interrupt,
better
Dr.
compared to
we are
whole
running
posterior.
short of time.
Yeah, I'll need additional and 1 minute. So in the discussion, average risk medulloblastoma, reduced boost volume from the posterior fossa to a limited tumor bed boost was not associated with inferior outcome. Reduced dose radiation to craniospinal axis in children aged 3 to 7 years was associated with worse event-free survival and overall survival. It was also noticed that there is a high incidence of incorrect institutional staging or pathology. Smaller radiation boost volume did not affect patterns of failure. None of the posterior fossa recurrences occurred outside the boost volume. No significant increase in isolated neuroaxis failure in younger patients. Second, malignant neoplasm remain a problem, and as early as within 1.9 years of treatment, patients developed some gliomas. WNT subgroup patients had favorable outcome. Inferior outcome was noticed in low dose CSI group, when primarily by group 4 patients. SHH subgroup patients receiving posterior fossa radiation experienced worse CFS. IQ was significantly less in younger children with low dose CSI compared with those with it was better with low dose CSI. Smaller radiation boost volume did not affect long-term IQ. Children aged 8 years and older at diagnosis treated with standard dose CSI exhibited no decline in IQ following treatment. Impact of radiation on hearing loss was not significant. So to conclude, dose-reduced CSI for young children with average risk medulloblastoma resulted in an unacceptably inferior event-free survival and overall survival that was predominantly driven by a single medulloblastoma subgroup or group 4. By contrast, a reduction in radiation boost volume was safe and effective for all patients and was much better for SHH group. So perhaps the future lies on the molecular stratification, and the standard solution can be standard dose CSI and reduced volume involved field radiation to posterior fossa for all children in absence of any molecular subclassification. So with this, I conclude and thank the organizers once again.
Thank you so much, Dr. Dudul. It was very well presented publication. Now I want to ask expert comment from Dr. Nidhi ma'am.
This is very interesting and upcoming field, and it is already being explored in outside the trial setting also. And the more trials will come, and we will then be in a position to take up whether IFRT will be better for the other molecular pathologies also.
I agree with ma'am. That's really area of active research, and we have to wait for more data to come in.
Yeah, rightly said, ma'am. Now, as we are running short of time, so I want to give over to organizers for the next session. Thank you so much, ma'am. Thank you so much for your presence. And thank you so much, all the participants.
So I think for the next session, now we invite Dr. Rajendra Yadav. Dr. Yadav is a director and head of urology at Fortis Hospital, Shalimar Bagh, and he will be conducting the urology session. Welcome, Dr. Yadav, and over to you.
Thank you, Dr. Vinita, and good evening to everyone. This urology session has 3 speakers, and I am going to introduce all of them in continuity. So the first speaker is Gagan Prakash, who is a surgical uro-oncology consultant at Tata Memorial Hospital, Mumbai. And he is going to speak what has happened in the last year, that is 2021, in nutshell. And the second speaker is Mudassar Ahmed, who is going to speak on a trial, PRISM trial. And he is medical oncologist and senior consultant at Fortis Noida. And the third paper is a PARP inhibitors. He will discuss about oligoprib and in HRRM and CRPC. Dr. Samir Khatri is going to discuss this paper, and he is consultant medical oncologist at Shanti Mukund Hospital. So first I invite Dr. Gagan Prakash to speak on what has happened in this year 2021.
Aruna, please start the video.
Good evening, everybody. I would be talking about urological oncology in the year 2021. Let me start by thanking all the organizers for this invitation. And this invitation has been particularly special for me because it was from Fortis Vasant Kunj in Delhi that I started my journey in urology in the year 2008. You'd see some familiar faces over here in this picture. So when Dr. Shubham called me about selecting the best 10 to 12 studies in urological oncology in the year 2021, you can see that's me talking to Dr. Shubham over the phone and having a really tightrope walk, because I had to select between surgery, radiation, and medical oncology. I had to select between RCTs and meta-analysis versus some less robust studies, organ-wise distribution. Most RCTs would probably happen in prostate and kidney, but possibly penile cancers and other gastric cancers are equally relevant for us, or even more relevant for us.
हाँ मैम ऐसा होगा मैम अगर आप वहाँ से कर सकते हो क्योंकि हम आपसे एक्सेस ले लेंगे
More relevant in the Indian context. And of course, some of the buzzwords which most of us are talking about. And I've tried to create a balance, considering all these things in mind. Let's dive straight into a flashback of 2021 and start with prostate.
Everyone, please mute yourself.
So,
Dr. Gagan,
PSMA PET scan has gone beyond diagnostics, and it's got a therapeutic role now. And also, let's see if it can help us select patients better for lymph node dissection. Now, this was a phase 2 randomized trial comparing lutetium PSMA therapy versus cabazitaxel, and which was published in Lancet this year. And essentially, they looked at the PSA responses and found that it was better than cabazitaxel in lutetium PSMA. Also, the grade 3 to 4 adverse events were lesser with lutetium therapy versus cabazitaxel. And they concluded that lutetium PSMA is a new effective class of therapy and a potential alternative to cabazitaxel. These patients were the ones who had already received some other lines of therapy in metastatic prostate cancer. And our dear friends at PGI Chandigarh published this really exciting results of another phase 2 non-inferiority trial just a week prior from PGI Chandigarh. And they actually went a step ahead, and they used lutetium PSMA in patients who were chemo-naive. So they compared it with docetaxel, and they actually found that it's non-inferior. They looked at PFS rates at 6 months, which were 30% and 20% in lutetium PSMA versus dosi, and also the grade 3 adverse events were lesser. They concluded that lutetium PSMA was safe, non-inferior to docetaxel in the treatment of metastatic CRPC, and could thus potentially be employed earlier in the disease course rather than being solely reserved for advanced end-stage disease. Now, can PSMA PET scan help us select patients who may not need a lymph node dissection? So there was a head-to-head comparison between MRI and PSMA. Most patients before undergoing surgery would have an MRI and a PSMA PET scan these days. Now, whereas PSMA PET scan fared far better compared to an MRI in terms of the sensitivity in picking up lymph node mets. It was 0.71 versus 0.4. But it still means that 30% of patients who got PSMA negative with respect to lymph nodes could still harbor lymph node metastasis. And so it's not good enough to let us, skip lymph node dissection in patients. Next, let's talk about adjuvant versus salvage radiation therapy after radical prostatectomy. So we've known that some of the RCTs were published in the last 2 to 3 years, last 2 years actually, and this was a meta-analysis of 3 RCTs published in the Lancet this year. And patients who had prostatectomy for high-risk localized or locally advanced prostate cancer, and if they've got these adverse features like a T3 disease or a high Gleason or a positive surgical margins, one would want to give adjuvant radiation therapy. That's what was being followed so far. And this particular study compared that versus giving it as a salvage when the PSA started rising. And the primary endpoint was an event-free survival, which was based either on the biochemical based on PSA, or clinical or radiological progression, or initiation of non-trial treatment, or death, or an absolute PSA value of more than 2. And these three randomized trials actually, Radicals, Raves, and GTUG-17, all of them looked at this. And the meta-analysis actually concluded that the use of adjuvant radiation does not improve the event-free survival. And they were kind of the effect of this. I mean, there's no added advantage of giving adjuvant over salvage, was across groups, based on the Gleason score, or whether the Samalva cycles were involved, or the surgical margins were positive. So the conclusion of the study was that adjuvant RT does not improve event-free survival, and we could possibly be sparing many men from radiation therapy and its associated side effects if we choose salvage instead of radiation therapy. More for the surgeons here. So once you've done the prostatectomy and you considering that you've done a nerve-sparing prostatectomy, what's the best way to have or restore erectile function in these patients? And there was a meta-analysis of randomized trials here. And amongst various techniques, actually, the pelvic floor muscle training and 100 milligrams of sildenafil were the ones which were found to be important and making a difference over here. And it suggested that a regular high dose of phosphodiesterase 5 inhibitors, not just sildenafil, any one of these, does make a difference. And it has to be a regular. It's not just trying to use it as an SOS or on-demand basis. Now, this is particularly relevant in the Indian context, where we operate on a lot of high-risk, localized patients. And so we've had studies in the past when only ADT was used in these set of patients, and it was shown that it makes a difference in the margins, but not in terms of survival. But now with the newer hormonal manipulators in place, they've been attempting to see if neoadjuvant intense hormonal therapy makes a difference in when we operate these patients after these therapies. And the endpoint in this study was the time to biochemical recurrence. So interestingly, following neoadjuvant therapy, around 21% of patients had a residual tumor which was 5 mm or lesser. And in 9.4% of patients, there was pathological complete response in the specimen. Well, I think it's a little too early to say that it should be being used, but this does pave paths for more randomized trials, which I believe are ongoing. Now, you would have heard about the POP-RT, which has been creating a lot of waves globally, particularly amongst the radiation oncology community. And this was led by Dr. Vedang Murthy at our institute. A study of almost a decade, which got published in JCO this year. And essentially, when you're radiating patients with high risk localized or locally advanced prostate cancer, the question was whether only the prostate should be radiated or the radiation field should include the pelvis and the pelvic lymph nodes. And this was a phase 3 study, and all node negative prostate cancer patients who had an estimated nodal risk of more than 20% were eligible. And in the standard arm, which was prostate only RT, 25 fractions 68 gray was used, whereas the whole pelvic RT, there was an addition of 50 gray 25 fractions to the pelvic nodes, including the common eye. And these patients were stratified by the Gleason score, type of ADT, PSA, diagnosis, and whether they've had TURP prior or no. The primary endpoint was 5-year biochemical failure-free survival, and the secondary endpoints were DFS and overall survival. Now, there were 224 patients who were randomly assigned to either of the groups, and a follow-up of 68 months. The 5-year biochemical failure-free survival was 95% with whole pelvis versus 81.2% with prostate only. Whole pelvis also showed a higher 5-year DFS, 89% versus 77%, and a distant metastasis-free survival was also better here. This trial kind of, it had a very strong conclusion and clearly a practice-changing study, saying that prophylactic pelvic irradiation for high-risk locally advanced prostate cancer improved biochemical failure-free survival and DFS as compared to prostate-only RT. OS did not appear to differ though. Let's now switch gears and go to non-muscle invasive bladder cancer. There's been a global shortage of BCG, and there have been attempts to know if the conventional schedule of giving BCG can be tweaked a little. And this was the Nimbus trial, another phase 3 randomized trial, where they used a different frequency. So essentially, instead of 6 weekly inductions, only 3 inductions were used, and each time a maintenance, which is giving like a 3 weekly thing. Instead of that, only 2 weekly maintenance were given at the same month, 3, 6, and 12 months. And it was actually found that this reduced frequency was inferior to the standard schedule regarding the time to first recurrence. So it said that one is supposed to stick to the conventional schedule. Muscle invasive bladder cancer. So, we conventionally use either MVAC or dose-dense MVAC or a combination of gemcitabine and cisplatin as an adjuvant in bladder cancer. And this study using nivolumab versus placebo in MIBC for adjuvant got published in the NEHGM this year. And essentially, they looked at the median disease-free survival, percentage of patients who are alive with disease-free at 6 months, median survival from recurrence outside the urethral tract. And they found that this nivolumab was better than placebo in all these parameters. And these were clinically significant in populations with PD-L1 expression level of 1% or more. There were obviously more adverse events in the nivolumab arm, 17.9% compared to 7.2% from the placebo. But essentially, this looks like an alternative and might be relevant to our country, where many of our patients actually with locally advanced disease presents are ineligible for receiving cisplatin, and for logistical reasons, often it is difficult to give MVAC or dose dibs MVAC. Another study in the NEGM for metastatic urothelial cancer, and where avelumab was used as a maintenance therapy. So essentially, you've used your 4 to 6 cycles of gem-cis or carboplatin, and after that, either there's only best supportive care or there's best supportive care with avelumab. And they found that the overall survival at 1 year was 71.3% in avelumab versus 58.4% in the control group. And there was some advantage in the PFS as well. They concluded that maintenance avelumab plus best supportive care significantly prolonged overall survival as compared to best supportive care alone among patients with urothelial cancer who had disease that had not progressed with the first-line therapy. For the surgeons, so, we would kind of really not look into this, or clearly underreported parastomal hernias after ileal conduit. So, if they like actively looked into either radiologically or clinically, it's a significant number, and there was possibly a need felt to do a trial and see if a prophylactic mesh could be placed to prevent these. And so when you look at clinical parastomal hernias in the control arm, standard arm, the incidence is as high as 23%, whereas when you prophylactically put a mesh, it comes down to 11%. Whereas if you measure these things radiologically, then it's around 25% and it comes down to 19%. So the study actually concluded that prophylactic implantation of a lightweight mesh decreases the risk of parastomal hernias when constructing an ileal conduit. And they also obviously looked at the complications. So it doesn't really increase the complications at 90 days related to the mesh. So let's now talk about stenting. So I put it as bladder because this would be relevant both for non-muscle as well as muscle invasive bladder cancers. But a scenario which very often we would see and do, and not possibly haven't given so much of thought to it until this some randomized trials were done, and now there was a meta-analysis published about it. So what happens is that when one is doing a TURBT, and if the tumor is close to the orifice, the ureteric orifice also is included in the resection. One has to include it in the resection. And with the apprehension of this patient developing a hydronephrosis, one would want to stent this patient, put in a DJ stent, or even some patients who have an hydronephrosis to start with, and one would want to put in a DJ stent, or one would want to do a PCN or a nephrostomy. Now, what this study found was that if you do stent these patients, then the chances or the odds of developing a metachronous upper tract urothelial carcinoma goes up with an odds ratio of around 3.49. And so this is something which one should not be doing. But if one has to do it, then there's no difference between putting a DJ stent versus a nephrostomy. So they actually looked at the chances of developing a metachronous in both the scenarios, and the difference isn't between the two scenarios. But there is clearly a high chance of developing a metachronous upper tract urothelial cancer. Let's go to RCCs now. So largely, for medical oncology, a lot of studies and trials. So adjuvant TKIs in RCC. Now, last 3-4 years, actually, there have been various RCTs, and they've proven, I mean, we know that there's no role of adjuvant, there's no proven role of adjuvant TKIs when you operate on high risk or large bulky kidneys, T3 or nodal positive disease. But this was an interesting concept which I wanted to highlight. So now they have a living systematic review, which possibly, things which systematic reviews which get updated by themselves, and they say it's a concluded living systematic review and meta-analysis that there is no advantage of having adjuvant TKIs. But at the same time, this year, the NEGM published adjuvant pembrolizumab after nephrectomy in renal cell carcinoma, and they did see a DFS advantage at 2 years. which was 77.3% with Pembro versus 68.1% with placebo. And they concluded that Pembro treatment led to a significant improvement on DFS as compared to placebo after surgery among patients with kidney cancer who were at high risk of recurrence. The OS figures are still not available. Now, another scenario with RCCs is about cytoreductive nephrectomy. So, what's happened is that with Carmina, the role of cytoreductive nephrectomy, the advantage of cytoreductive nephrectomy was not, I mean, it was proven that it's not there, and essentially one doesn't need to do it, doesn't add an advantage in terms of survival. But then by the time Carmina got published, we had moved to an immunotherapy era, and the same question kind of came in front of us again. And so this study was actually a meta-analysis examining both, particularly in patients who are receiving the modern therapies, the immunotherapies. And the pooled analysis actually indicated an improved survival with cytoreductive nephrectomy in patients who've received targeted therapy and in immunotherapy. And they concluded that in this observational data set, a larger survival benefit was seen in cytoreductive nephrectomy in patients who received these regimens, and that the results of Carmina do not necessarily preclude a benefit to cytoreductive nephrectomy when combined with immunotherapy-based regimens. Although I think it's too early to make a very strong statement on that, because that was the way things evolved even with TKIs. We always thought that it's going to make a difference, but the trials proved to be the other way. Yeah, so next is about the first line in metastatic RCC. So, we know that sunitinib is what had been used. So, some point in time, they had started a trial comparing nivo plus cabozantinib, and this got published in the NEJM this year. And at a median follow-up of around 18 months, the overall survival and the median progression-free survival was 16.6 months in nivo plus cabozantinib versus 8.3 with sunitinib. And they said that nivo plus cabozantinib had significant benefits over sunitinib with respect to PFS, OS, and the likelihood of response in patients with previously untreated advanced RCC. So possibly, we have a new option in the first line, obviously at a much higher cost though for our patients. The similar scenario where they've used lenvatinib plus pembro, in advanced RCC, and they found that lenvatinib plus pembro was associated with significantly longer PFS and overall survival than sunitinib. Now, this particular study is it's kind of different because this was a randomized phase 2 study for non-clear cell RCC, where we didn't really have much robust data so far. We would extrapolate things from other studies, and this was in advanced papillary RCC, is obviously a multicentric study, got published in the Lancet this year, and there were 4 drugs essentially: cabozantinib, crizotinib, savolitinib, and sunitinib, and they found that cabozantinib possibly fares the best. Cabozantinib resulted in a significant longer PFS compared with sunitinib in patients with metastatic RCC, and this is the conclusion of the study. So finally, something for the surgeons here, cooling, or we know that when we do a partial nephrectomy, we would use hypothermia, use an ice slush to cool the kidney. And finally, there's actually an RCT which has compared cooling versus no cooling, and they haven't found a difference essentially. So they've looked at the change in the GFR at 1 year after surgery, and they've also looked at the GFR specifically for the operated kidney and found that renal hypothermia doesn't make a difference. So I think some possible good news for the MIS or the robotic surgeons. Penile cancer. Now, as is expected, penile cancer doesn't have many RCTs or meta-analysis because of it being such a rare tumor. But I think at the same time, when we look at the incidence of penile cancer in India, we are the ones who possibly can create these more robust studies in penile cancer. I was surprised to look at the recent data from GloboCan that the incidence of penile cancer in India, which is close to around 1.6 per 100,000, is not far behind kidney cancer and bladder cancer in India. Whereas that difference is huge when it comes to the Western countries. So again, from TMH, Dr. Vedang and Dr. Rahul Krishnatri, they actually looked at PN3 specifically, and this is a question which perplexes all of us, to whether to use only chemo or chemo with radiation therapy, or only radiation therapy. And essentially, the impact study which is ongoing is something which is looking at all these aspects, but has been a really poor accrual so far. Some of the Indian centers hopefully should be joining on board for the impact study. But till that time, this particular study, what it adds is that PN3 because of a pelvic node versus PN3 because of an external extension of a groin node behave differently. That's number one. Number two, if it's PN3 only for the groin, then either of the modalities, either chemotherapy or radiotherapy, the patients were doing kind of similar. Whereas if it's PN3 because of the pelvic nodes, then it has to be a multimodality, because it does leads to a better survival and a better outcome. And if you're talking about using radiotherapy more often in the groin, then the next obvious thing is related to the toxicity, for which there was again some work by Dr. Vedang, and they essentially said that the contouring which was not defined so far could be better defined, and when we do that, we find that there is a funnel-shaped distribution of nodes, and possibly with this kind of an approach, the toxicity for which groin radiation was into disrepute for many years could possibly be reduced by having these contouring guidelines in place. The next is about N0 groins in penile. So what's happening is that all this while we have the EAU risk stratification, the low, intermediate, and high risk, and we would use that to predict who are the patients who are likely to develop nodes or having micrometastatic disease. And this year there were essentially 3 studies, and 2 studies from India, one from GCRI and the other one from TMH. And we found that there are other factors, particularly LVI and PNI. PNI was also looked at, this study published just a couple of weeks back from Adyar. And possibly these factors make a much larger difference compared to the T stage or other things. And maybe there could be role of having an interval surgery where the partial penectomy is done, and we have all these pathological pathological features which can more accurately predict the patients who are likely to have a micrometastatic disease. And finally, we have the testicle cancer. So essentially 2 areas where they've been work predicting residual disease options beyond tumor markers, and the IGCCC updates. So microRNAs are not new in oncology. Most of us know about them, but they've been studied a lot in testicular cancer. So what happens is that between seminoma and necrosis and teratoma, if we could have a tool to kind of predict it, what's happening, we would save a few patients from the complications of RPLNDs, and the existing tools, which is essentially the tumor markers, the AFP, beta, HCG, and LDH, we know their limitations, and that's where microRNAs are being used. There have been various studies going on, which I'm not going into the details, but essentially this review from Nature Urology kind of summarizes how microRNAs fare compared to the tumor markers, alpha fetoprotein, beta HCG, and LDH, when it comes to non-seminoma, seminoma, when it comes to various components of non-seminomatous tumors, and in terms of predicting residual tumor, in terms of predicting relapse. And these 2 studies, both, I would call them twin studies, published in the JCO these years, an extremely good attempt at looking at what we've been doing so far. So they've actually looked at a much larger data set, a multicentric study of patients with germ cell tumors, both non-seminomatous as well as seminomatous published separately, and they've tried to validate and see whether the IGCCG holds good with the modern therapies, better utilization of chemo, more evolved RPLND techniques. And they found that actually the outcomes of patients across good, intermediate, and poor risk in both are better today than compared to when this classification was first proposed. And also they have, pointed to, at least two new factors, which possibly could be making a bigger difference in terms of these patients, how these patients fare. So in non-seminomatous, it is age and the presence of lung metastasis, whereas in seminoma, it is LDH cutoff of 2.4, 2.5. And obviously this paves the path for larger studies and randomized trials looking at these factors, how they can make a difference. So yeah, so that ends this Oncology review for 2021, and this is the team at TMH, the Urology DMG. Many of the names you would have seen in the slides that I had shown. Thank you for your attention.
Thank you, Dr. Gagan. Nicely compiled papers, and we have learned so many things about urology, oncology. Now I invite Dr. Mudassar Ahmed to speak on PRISM.
Thank you, sir. Thank you, sir, for kind introduction. So yeah, this is Dr. Mudassar. I'm from Fortis Hospital, Noida, and today I'm going to present a phase 2 randomized trial of nivolumab in combination with an alternatively scheduled ipilimumab in the first-line treatment of advanced renal cell carcinoma. Yeah, so this trial was originally presented by Dr. Naveen Vasudev from Leeds in the recent ESMO Congress, and yeah, so the background of this trial is that we know that in view of many of the trials which have been noted by Dr. Prakash and this last 1 or 2 years have been happening for the renal cell carcinoma. And ipilimumab plus nivolumab is an approved first-line treatment for the patients with intermediate and poor risk advanced clear cell renal cell carcinoma. This is according to the Checkmate 214 trial. And these were the results. They were excellent results with a 42-month median overall survival of like 47 versus 26.6 months. So this was an excellent, and that led to the approval for this combination. The only problem, the most important problem with this combination was that it showed a very good benefit, but half of the patients experienced grade 3 and 4 treatment-related toxicities. It was so much so that about 22% of the patients discontinued treatment because of the treatment-related adverse effects. And because of the simultaneous development in some other cancers like the lung cancer, non-small cell lung cancer, melanoma, as well as renal cell carcinoma, there have been studies into the dosing and frequency of the ipilimumab, and it has been seen that the dose and frequency of ipilimumab is related to the toxicity. The optimal scheduling of ipilimumab in combination with nivolumab in advanced renal cell carcinoma has not been defined. This was till the time of the designing of this trial. There have been some trials like in melanoma where 10 milligram per kg of ipilimumab every 3 weeks plus 4 doses, for 4 doses was associated with a longer median overall survival, but had significantly higher grade 3 and grade 4 toxicities. Similarly, in another study in melanoma, we studied ipilimumab 3 milligrams versus plus nivolumab 1 milligram per kg versus ipilimumab 1 milligram per kg and nivolumab 3 milligrams per kg. And they showed that there was favorable toxicity profile with this alternative schedules. This is the latest NCCN guideline, and this slide is only to show you that there are like 4 category 1 indications, 4 category 1 protocols and regimens in the advanced renal cell carcinoma. There's axitinib, pembrolizumab, cabozantinib, nivolumab, ipilimumab, nivolumab, as well as lenvatinib, pembrolizumab. And by every month, we are getting new approvals for the same. So this, coming back to the study, this is from the PRISM group. They included patients who were treatment naive, locally advanced or metastatic renal cell carcinoma. They must have had a clear cell component in their histology and a good performance status. They included all IMDC risk groups and stratified them according to the IMDC risk score, nephrectomy status, and metastatic versus locally advanced status. And they randomized all these patients, in 2:1 fashion in favor of that means 2 times the patients were going to the modified ipilimumab arm. So the 2 arms, that is I'll use the pointer. So this is very important to note about this study, because this is important to take conclusions from this study, is that the 2 arms of this study, that is the modified ipilimumab arm and the standard ipilimumab arm, which were the 2 arms of this study, they were compared with each other in terms of the safety. That means only safety was compared in between these 2 arms. Efficacy was not compared. Efficacy, they compared the modified EP arm, that is the experimental arm, with the historical control, that is the sunitinib from the CoMpass trial. That is, they compared the 12-month PFS associated with sunitinib in the CoMpass trial with this modified ipilimumab arm. This was because at the time of designing of this trial, the results of the checkmate 214 were not completely out, though they compared the toxicity profiles with that trial. To explain the schedules better, I am putting here that the nivolumab schedules in between the 2 arms were similar. That is, they were used as a flat dose of 240 milligrams every 2 weeks or every 4 weeks, which was similar between the 2 arms. But the ipilimumab was used in the standard arm as 1 milligrams per kg body weight every 3 weeks in the standard arm, while in the modified arm, that is the experimental arm, it was used as every 12 weeks for 4 doses. The primary endpoint was actually the toxicity endpoint or the safety, which actually tried to detect the grade 3, grade 4 treatment related adverse events within the first 12 months of the therapy. The key secondary endpoint was the efficacy endpoint, which was the progression-free survival. The primary endpoint was compared with between the 2 schedules of the Nivo-EP, but the key secondary endpoint was comparing the PFS with the historical control, that is the sunitinib from CoMpass trial. Additional secondary endpoints were treatment tolerability, PFS, overall response rate, overall survival, duration of response, and the quality of life. This study was not powered enough to detect the difference in efficacy between the 2 Nivo-EP arms. Baseline characteristics were fairly matched. About 70% of the patients had intermediate or poor risk IMDC risk scores, and 60% of patients in both the arms had undergone a nephrectomy for their treatment. Lung metastases were the most common, and they were fairly well matched. Median follow-up was up till 19.7 months. This is the primary endpoint of this trial. You can see that the grade 3, grade 4 adverse events, treatment-related side effects within the first 12 months In the modified EP, it was only 32.8% of the patients had this adverse effect, which was fairly less than 53.1% in the standard EP arm, with a difference between these two arms of 20.3%, and which amounted to an odds ratio of 0.43, which was highly statistically significant. So there is no doubt, according to this trial, that the modified EP schedule is safe, and it's the safety wise, it is better than the standard schedule. If we break down the toxicities which were different between the two groups, two arms, were arthralgia, increased lipase, and colitis, and hypophysis, and the hyperthyroidism. These were the only things which were less in the modified EP schedule. The discontinuation rates, according to the against the treatment-related toxicities, were 22.7 in the modified schedule versus 39.1 in the standard. So it was significantly less. So we can say that they were the modified EP schedule was significantly safe and better than the standard schedule. Now, this progression-free survival, as I mentioned earlier, was not compared with the standard Nivo EP arm. It was compared with the historical data from COMPASS trial, again is the SUTENT. The 12-month PFS rate was 46.1%, which was numerically more than 39.7% in SUTENT from COMPASS, but the lower limit of the confidence interval was below the historical rate for SUTENT. So we have to take this into consideration while taking the data from this, taking conclusions. The progression-free survival, if we compare, this is actually not to be compared, but this is actually an informal comparison. If we compare the two treatment arms, that is the modified EP arm versus the standard EP arm, the progression-free survival was, these are the curves, and they are hugging each other, and we can easily say that they are same or similar. The modified EP arm had 10.8 months versus 9.8 months with the standard EP arm. If we take the only the intermediate and poor risk subgroup, you can again see that these two curves are still hugging each other, and the median PFS was still comparable between the two, though we have to take it that it was not powered enough to see this difference. Objective response rates between the two arms, the modified EP and standard arms, were similar. It was like 46.7% versus 40.9%. And the median duration of response was also similar. Overall survival was not mature, so the median overall survival was not mature, but the 12-month standard, landmark overall survival rate was 88.3% versus 83.7%, which was fairly similar between the two arms. These are the authors' conclusions that in this cohort of treatment-naive advanced renal cell carcinoma patients, ipilimumab 12 weekly instead of 3 weekly led to a significant reduction in the proportion of patients experiencing grade 3, grade 4 treatment-related toxicities. Though the lower limit of the confidence interval for 12 months PFS observed in the modified EP arm failed to exclude the rate associated with the historical data, that is the SUTENT from the COMPASS trial. However, the median PFS, overall response rate, duration of response, and the 12-month landmark overall survival were comparable between the two EP-Nivo arms. This positive, phase 2 trial supports further exploration. So I don't know whether we can take conclusions from this, but it certainly supports that we should be, exploring further into these modified schedules so that we can actually decrease the toxicity associated with these regimens. Thank you. Back to the
Thank you, Dr. Ahmed, finishing in time and presenting this paper. Next speaker, I invite Dr. Samir Khatri. He is going to present the PARP inhibitors, so that is olaparib in HRRM in metastatic resistant cancer of prostate. So I invite Dr. Khatri, please present your paper.
Good evening. At the onset, I would like to thank the organizers for inviting me for this talk. Today, I will be talking about this trial, the PROFOUND trial, and what is the role of olaparib, that is the PARP inhibitor in HRR mutated metastatic CRPC. So this will be the agenda for the today's talk. We will be talking about the prostate cancer, what is the molecular heterogeneity, what is the role of PARP inhibitors in this, and how the guidelines have recommended the PARP inhibitors. So we talk about the epidemiology of prostate cancer. So it ranks 16th incidence-wise in India with the reported cases of about 26,000 and causes about 17,000 deaths as per the Globocon 2018 data. And we all know that prostate cancer, it comprises of multiple disease states. It can be either localized, non-metastatic CRPC, hormone-sensitive metastatic prostate cancer, or the metastatic CRPC. And today we will be focusing on this, the metastatic CRPC. So why there is an ongoing need to improve the standard of care for men with metastatic CRPC, because we have multiple options available to us as far as the treatment is concerned. But how to optimally sequence this treatment, it remains not very clearly defined and remain very poor. So metastatic prostate cancer, as we know, it is biologically a very heterogeneous disease with approximately 90% of metastatic CRPC patients, they have genomically aberrant pathways involving either AR, the PI3 kinase, DDR, WNT, or cell cycle related signaling pathway. So, but important thing is that 23% of these patients, they have this mutation in the DNA repair pathway. So mutation in this DNA repair pathway, this leads to the genetic instability, and this derives the tumor growth. So these are the important ones, the ATM, BRCA1 and 2, PALB2, CHEK1 and 2, and RAD51. And this is the homologous recombinant repair, that HRR. This holds the key mechanism for repair of double strand breaks in the DNA. So this forms a background and the rationale for the use of PARP inhibitor, because we know that despite significant progress in systemic therapy, this metastatic CRPC, this continues to be a lethal disease, and there is a molecular heterogeneity with approximately 20%, 30% of the patients harboring this deleterious alteration in HRR, and these gene alterations, they form the backbone for using PARP inhibitors, and these PARP inhibitors have been shown in trials to have been effective in HRR alterations. So now coming to this trial, this very important trial, that's phase 3 study evaluating the efficacy and safety of olaparib versus the new hormonal agents and HRR mutated metastatic CRPC. And these were the patients who have documented CRPC and had a qualifying HRR mutation. There were two cohorts, cohort A and cohort B. And cohort A, this constituted the three main alteration, that is BRCA1 and BRCA2, along with ATM. And in cohort B, these were the other HRR mutated tails. And these were given into 2:1 randomization with olaparib in the standard dose of 300 milligram BID versus physician choice. And there was an optional of olaparib on progression. And these were the main endpoints. The primary endpoint was the PFS, the radiological PFS, and the secondary endpoint was the overall response rate. And there was a combined cohort A and B radiological PFS, time to pain progression, and overall survival, and safety and tolerability. So these were the 15 gene panels which were used, mainly the BRCA1, 2, and ATM, and other genes in the cohort B. This was the foundation 1 gene study. And these were the baseline characteristics. If we see, these are very well matched in both cohorts, cohort A, and if we talk about cohort A plus B, if we see, there was more visceral metastasis in physician choice in both the cohort, and there was more ATM alteration in the olaparib arm. And similarly, there were the characteristics were even the PS and all those things were evenly matched. So BRCA2, ATM, and CDK12, these were the most prevalent genes of qualifying genes alteration in the randomized patient reported. And if we talk about the results, this the primary endpoint, this olaparib, this significantly improved the radiological PFS in those patients who had this alteration in BRCA1, 2, or ATM, that is the cohort A. And if you see, there was an early separation of the curve as early as 8 weeks. And olaparib benefited across all the pre-specified subgroups in cohort A, and there was more patients who had the objective responses with BRCA1, 2, and ATM mutation. They responded better, 33% versus 2.3%. And again, those patients who had this alteration, they had a favorable trend in overall survival. And if we talk about now the cohort A plus B combined, so there was a statistically significant and clinically meaningful improvement in PFS if we talk about cohort A and B. And again, the pre-specified subgroups, overall population, this had olaparib were doing better. And again, if we see cohort A plus B, the overall objective response rates were better with olaparib. And if we talk about the favorable trends in OS, it was definitely there. And remember, there was more than 80% of the patient, they had a crossover. So olaparib arm showed 17.5 months of median overall survival versus 14.2. And this is also very interesting. The median time to pain progression, it was again significantly increased when we used olaparib versus the physician choice in the cohort A and also in the cohort A plus B. And now there is evidence of clinical activity of olaparib in patients who had alterations in genes other than BRCA also. So not only the BRCA mutated and ATM, they benefited, but other genes also benefited with olaparib. So even those patients who had prior taxane use, they also benefited in both cohort A and cohort A plus B. So there was a better PFS and OS even when the patient had prior taxane uses. And if you talk about the median duration of treatment with olaparib in the cohort A, it was nearly double. And now coming on to the adverse events, if you see, there was very well tolerated. Most common side effects being the anemia, nausea, and vomiting in olaparib arm, and about 4.3% of the patient in olaparib had pulmonary embolism versus 0.8%, and there was no reports of MDS or AML. So these are the main adverse events of special interest with olaparib. Hematological, as I told, is hematological toxicity, a recognized complication of olaparib, with about 21.5% of patients experience more than grade 3 anemia, more than 3.9% had more than grade 3 neutropenia and grade 3 thrombocytopenia. So key takeaways from this study are that profound is this is the first positive biomarker study, phase 3 study, which have shown the usefulness of olaparib, only PARP inhibitor to show improvement in OS. Olaparib has shown to be beneficial in terms of other patient-related endpoints like PFS, overall response rate, and time to pain progression. Despite more than 80% crossover at interim analysis, olaparib had a favorable trend in OS, and olaparib was very well tolerated. So now we all know that tissue is always an issue. And what happened in this study also, the majority of samples which were tested, they were the archival core biopsies from the primary tumor. About 90% of them were there. And test success rates were higher in newly collected as compared to the archival samples. And the quality of NGS based HRR mutation testing depends on the adequate sampling, the quality of sample. And if the quality of sample is not there, then the test can fail. So the test failure is a possibility, and mostly it happens when this DNA extraction, there is a failure of DNA extraction as there is insufficient DNA yield to proceed with the testing. It can be either due to the pathology failure, DNA extraction failure, as there is insufficient DNA yield, or failure after DNA extraction, DNA quality not adequate for the NGS. So current testing practices to assess this HRR testing, either it can be the germline or the somatic. Germline meaning that we can take the blood sample, which is most commonly being used nowadays, or the tissue testing or ctDNA or CTC testing. So tissue is definitely an issue, and this is a preferred algorithm that initial tissue testing, it is followed by germline mutation testing if there is insufficient sample or there is no tissue in the absence of validated ctDNA testing. So key takeaways for testing is that majority of samples assessed in PROFOUND study, they were archival, about 90%, and failure rate was as high as 30%. Retrieval from the previous blocks from tissue banks or archives may be a challenge. So these are the key results of the PROFOUND study, last few slides, and there was definitely a better this radiological PFS in both cohort A and cohort B, and it met the olaparib met the other endpoints also. There were this olaparib benefited even when there was a previous taxane usage also. It was very well tolerated, and tissue success rates, their failure rates, as I've already discussed, it was due to that inadequate DNA extraction. So what I think is that PROFOUND is the first positive biomarker selected phase 3 study evaluating a targeted therapy in men with metastatic CRPC, and olaparib is the only PARP inhibitor to improve the OS and in HRR mutated metastatic CRPC, and highlighting the importance of getting genomic testing in this patient subgroup. So definitely after this study, all the guidelines have mentioned, even the NCCN is now mentioning the importance of testing and the importance of this. Thank you. This is my last slide. Thank you very much. So
thank you, Dr. Sameer. Now the paper is open for discussion or comments. Anybody from the audience wants to say anything?
Sir, I think we'll move on to the next session. I feel that once the time overruns for the organizers, it's a nice headache that it was an interactive session, but sometimes we have to think of the next session
it's
also.
All right. It's all right.
I
think there are hardly any comments.
Yes. No, sir, I want to thank you for actually chairing this session and taking the discussion forward. And in the interest of time, I will, Dr. Sameer mentioned about tissue being the issue, and I think there is no better group of people than pathologists to talk about tissue and how tissue becomes the major issue. And this is a major challenge, especially in the case of neuro-oncology, where we really cannot get tissue without involving the surgeons. So sometimes I feel that probably neuro is the field where surgeons rule the roost, but they are also dependent on the pathologist. So for this next session, I invite Dr. Sunita Elawat, who's the principal consultant and histopathologist at SRL labs at FMRI, Gurgaon, to talk about gliomas in 2021. This will be in the form of a case discussion and a panel discussion. The case will be presented by Dr. Gaurav Khanna, Senior Consultant Histopathologist at FMRI. The panelist will be Dr. Rana Patir. Sir is Director of Neurosurgery. Dr. Vinita Goel, Madam is Director of Radiation Oncology at Fortis Shalimar Bagh. Dr. Abhishek Raj, Medical Oncologist at BLK Max. And Dr. R.K. Gupta, sir, another very senior Director Radiology at FMRI Gurgaon. This session is open. Dr. Elawat and Dr. Gaurav, please go ahead.
Thank you, Dr. Shubham. It is an honor to be a part of this conference, and thank you for introducing all my panelists. Dr. Rana is going to join us in a short while because he's in the OT, so he will join. I don't see I saw Dr. Gupta.
So, ma'am, Dr. Abhishek is there, Dr. Vinita
Yes,
is there. Let me see. Dr. Gupta is here. Sir, you can unmute yourself, sir. Dr. Rakesh Gupta, sir.
And Gaurav also is there.
Yes, Dr. Gaurav is also there, madam. Dr. Gaurav, you can unmute yourself, please. Yes, unmute yourself and you can switch on your camera also. Yes, thank you so much. Thank you so much.
Hello, hi. Good evening, everyone. Hi, Dr. Abhishek. Good to see you here.
Hi, Dr. Gaurav. How are you? Good to see you.
Yeah. Let's find Dr. Gupta also.
Ma'am, sir is here. He's unmuted himself. Hi, Dr. Gupta, sir. Good evening.
Good evening.
Gupta, sir.
Good evening, sir. How are you, sir?
I'm fine, sir.
Can't miss this opportunity to share your knowledge with us. So, hi Abhishek. Hello, Vinita. So today we are without wasting time because we are already running about 20 minutes late. So we are going to cover a subject of neuro-oncology, which is in my time when I started doing pathology, it wasn't very popular area to work in. But now with time, this has become a very upcoming branch, and more so in last few years where the molecular part of pathology is being taken over in neuro-oncology. Until 2016, WHO classification included morphology and molecular markers for categorizing the CNS tumors. But in 2021, in these last 4 years, tremendous advances have taken place. The neuropathologists, neuro-oncologists have been very active. In 2021, the molecular markers have sort of taken over the morphology for classification and as well as for grading of CNS tumors. In fMRI, we have introduced these essential molecular markers, and we are going to discuss two cases. Dr. Gaurav Khanna is going to discuss. He's our very enthusiastic young Turk, and we are going to show you how these markers help us and to some extent confuse us. So, Gaurav, please start the presentation.
Yes. Shall I start the presentation?
Yes. Go for screen.
Yes. Can you see my screen?
Yes. Go full screen.
Okay. I'll be discussing, first of all, thank you so much for giving me this opportunity to speak on this quite common but gradually becoming difficult topic difficult in the sense that a lot of molecular work is being introduced, and which was very new for while while doing our MD. But now I think these molecular workup, all these molecular workup should come as a routine curriculum during the MD days. So coming without wasting further time, we'll be discussing two cases. So case one is a 38-year female. She was a doctor by profession, and patient was operated for left
Gaurav, your
front.
slides are not moving.
Your slides are not moving, Gaurav.
Now they are moving.
Okay. So this is the case one. I hope you are you are seeing the right slide.
Continue. Move to the next.
So this is a case of 38-year female who presented, she was operated for left frontoparietal tumor, which was diagnosed as grade 2 astrocytoma 10 years back. So for the last 10 years, patient remained asymptomatic, and but the screening scans in November 2019, which were done at our center, that showed a small lesion with a higher perfusion compared to the remaining lesions.
Sorry, can I interrupt?
Sorry, Gaurav, your
Gaurav,
slides are not moving.
Yeah.
So can I ask the Sudhir, our technical support?
Yes, ma'am. Anna, please share the slide.
Now it has come on the right slide.
It is better that we have taken the precaution of mailing the presentation to the conference secretariat so that if we had run into such issue. Yeah. So Gaurav, now you have to say next every time.
Okay. So the patient was 38 years female, presented for a routine screening scan in November 2019, and patient was operated outside our center at some outside hospital for a left frontoparietal lesion, which was diagnosed as grade 2 astrocytoma, and this lesion was 10 years back. For last 10 years, patient was asymptomatic for any disease, and till August 2021. Then patient presented with a single episode of weakness, vomiting, speech difficulty, and facial dilation. So this November scan in 2019 showed a small lesion at perfusion, and this was reported from our center. So next slide. Yes. So this is the 2019 scan in which there was a very small lesion which showed high perfusion, and there was X ratio sign of previous 10 years back operation. Dr. Gupta will definitely pour some more knowledge on this later on. So and the patient was advised to for manage to get the patient for this lesion because it was given a suspicious lesion. But the patient was didn't turn positive, and patient returned back in September 2021, almost 1.5 years after screening scan, and lesion was full blown, and it showed remarkably high perfusion in the frontal region. Temporal lobe was also injured, but they didn't show a very high perfusion. So it was a region which was very small in 2019, progressed to a tumor, full-blown tumor in 2021, in September 2020. So it was operated. Next slide.
Next
slide, please. Yes. So this was a very highly cellular tumor. We removed the tumor separately both the frontal component and the temporal component. And this image is belong to the frontal part of the tumor. The tumor was very highly cellular. You can see the cellularity. The tumor is very densely packed. Tumor cells are densely packed. And the black arrow shows the vascular proliferation, the glomeruloid vascular proliferation. So on the basis of dense cellularity, high nuclear and this microvascular proliferation, histologically it was turning into grade 4 glioma, that is glioblastoma. Not We can call it a glioblastoma only after IDH mutation status. So we'll go for the next slide. Next slide, please. Yes. Here we see giant cell transforming on the right side, and on the left side we can see this mitotic activities include atypical mitotic triggers. Next slide. Yes. GFAP was very weak positive in the usual cytoplasmic processes. IDH was negative. So this was IDH was one time, and ATX was lost, and then PCD was mutant. So ATX lost patient.
Okay, Gaurav, your voice is cracking. Can't hear you properly.
Now you're totally lost.
Hello. So PCD was mutant here. Am I audible?
You're audible, Dr. Gaurav. You're audible. Please go ahead.
Okay. So please go for the next slide.
We keep on losing you in between, Dr. Gaurav.
So I was waiting for the next slide. So OLIG 2 was weak and patchy positive. It was not diffuse positive. KIC7 was high. Next slide. Yes, this image, the SND image is of temporal lesion. Here the cellularity was low and there were microcystic changes. With microcystic changes and low cellularity and not much high-grade nuclear atypia, this area was showing low-grade histology. Next image. Yes, in this area also, but although the tumor showed low-grade histology, IDH was again wild type. It was not mutated. ATRX was lost, similar to the pattern which was seen in the high-grade areas. OLIG2 again, it was patchy in distribution, but Ki67 was low if compared to the high-grade histology. Next slide. So then the glioma panel showed MGMT was mutated. IDH1 was not detected even on sequencing. 1P and 19q codeletion was not there, but the third promoter mutation was detected. So based on the histomorphology, immunohistochemical profile and the glioma panel, it was a case of glioblastoma, WHO, CNS WHO grade 4, IDH wild type with third promoter mutated. Next slide, please. Yes. So the important thing I would like to highlight this case is that the lab which we think for the molecular study was the tumor which was low in histology, and as well as the block for the block showing the tissue showing the high histology, and both the tissues showed the third promoter mutation. So that means that the tumor which showed the low grade histology as well as high grade histology, both showed third promoter mutation, and it was a common origin. Uh, I hope everyone would have gone to this article which have come this year, mentioning all the updates. And adult diffuse gliomas are now divided into main entities: cytomas, mutant, oligodendroglioma, which are IDH mutant, and 190 coagulated, and then glioblastoma. Coming to the next slide, please. Yes. So astrocytomas in adults, they are for the first approach is IDH study of IDH mutation, which can be done by IS. If we come across, if we see that the IDH mutation is not there, that is non-mutated, as in our case, that is IDH wild type, then we look for presence of microvascular proliferation or necrosis. If that is there, that means it's a stage called glioblastoma. There is no need of glioma panel study as well. But generally, it could be completely classified to look for any target mutation for which some are available. And so it is advisable. It is in fact it is mandatory to get the molecular study to complete the diagnosis. So even if even if when the microscopic proliferation or necrosis is not there, the IDH is wild type, then the molecular study becomes very essential, because if we find any of these mutations like third promoter mutation, EGFR amplification, or gain of chromosome 7 with loss of chromosome 10, then we call it glioblastoma straight, even when the histological features of it are not there. So that's why this is very important. And if IDH is mutated, then the mutation or the molecular pattern is different. Like it is CDKN2A or 2B deletion. So that becomes important in the IDH mutated tumors. So this is the important thing that I want to convey, that the tumors which are IDH wild type, the glioma molecular study should be done to classify tumors, because it become a grade 4 tumor even when histological features are absent. Any of these mutations like third promoter mutation, EGFR amplification, or gain of chromosome 7 and loss of chromosome 10, if any of these three mutations are present, tumor become a grade 4 tumor irrespective of the histological features. Next slide. Yes, this is case 2. This is a 38-year male patient who presented with seizure speech difficulty. Next slide. And the radiology said there was some small focus which showed high perfusion. Predominantly, it was looking a low-grade tumor, lung perfusion. Next slide. There we can see the direction of the tumor, the cortical parenchyma. We can see that the tumor is diffuse infiltrating the cortical parenchyma, and there is no significant peripheral edema, which is characteristic of low-grade tumor. Unlike in high-grade tumors, which show to peritumoral edema. Next slide. Yes. The right half of the image is showing the cortical parenchyma on high part. We can see these vessels, linear vessels, and the tumor cells are infiltrating in the cortical parenchyma along these vessels. And we can see highlight these neuronal cells as well. And this is perineuronal satellitosis. So tumor is diffusely infiltrating the cortical parenchyma along the vessels and along the neurons. On the left side, the upper image shows the subpile parenchymal distribution. So in the next image, we can see that the mitosis is quite brisk. Next slide. Next slide. Yes, DFP is positive in the periphery nucleus cytoplasmic process. If IDH is strong and diffuse positive, that means IDH is mutated, ADR is retained, and P53 is Y type, and K57 is quite high in these cellular areas. So there were two distinct areas. One was very highly cellular, and the remaining tumor showed moderate cellular. the cellular areas showed increased mitosis. Next slide, please. Next slide, please. Yes. This I want to highlight that third promoter mutation was also there, but in this case, third promoter mutation does not increase the grade of this tumor. Instead, the histological grading criteria for oligodendroglioma remains as such, unlike in astrocytomas. That is, if we find mitosis more than 5% hyperphagia or we find necrosis or endothelial proliferation, then only we call it as a anaplastic or grade 3 oligodendroglioma. Anaplastic term is actually now obsolete. They don't advise to use the term anaplastic. So we call grade 3 in case of oligodendrogliomas based on histology only. And third promoter mutation does not make it grade 4 tumor. This is important, and I wanted to highlight this that the third promoter mutation plays a role in the tumors which are IDH wild type and not IDH mutant type. Yes, next slide, please. So this was the diagnosis. Oligodendroglioma CNS to grade 3 based on the historical symptoms of increased mitosis. The next slide. Yes. So, unlike IDH mutant diffuse astrocytomas, IDH mutation and 1p19p co-deletion oligodendroglioma lack the ATRS mutation. That's why the expression is retained, as we saw in this case. But virtually always carry activating mutations in the third promoter region. So, the third promoter mutation in oligodendrogliomas does not upgrade the tumor to grade 4. Which are IDH wild type or glioblastomas, which are IDH wild type grade 4. These are the two articles I have taken from the stalwarts in neuropathology. So there are a lot of publications on this. Yes. Next slide.
So Dr. Gupta, sir.
Yes. The thing is that a glioma which is IDH. So glioma which is IDH, there are histological features of microproliferation or they may call it as a grade 4 tumor. In case histological features are not there, then any one of these mutations would be there. When we call it glioblastoma IDH. The same does not apply to oligodendroglioma with IDH1 because the promoter mutation is commonly seen as a accompanying mutation in the oligodendrogliomas. These two are great. Thank you. Dr. Sunita, please take over.
Yeah. So Dr. Gupta sir, even molecular pathology has taken over morphology and a lot of advances which have taken place. So similarly in radiology also, the neuroradiology also, a lot of advancement have been taking place, and that you work so closely with brain tumors. So, what are the features and techniques which help you in grading the gliomas and especially the adult gliomas? Can you tell us briefly on this?
Actually, there are a number of techniques that are being used for the last 20 years. And initially, everybody thought spectroscopy will give all the answers. And I was a very enthusiast of doing a spectroscopy since 1990s. And gradually, I realized that it doesn't do that well, actually, as compared to the other techniques like diffusion imaging. And subsequently, in 2005, we started developing the technique in-house for perfusion imaging. And the perfusion imaging actually tells you about the angiogenesis, neoangiogenesis. And it doesn't mean that it doesn't occur in benign tumor, benign disease like infections. and other places. But tumor, certainly, if you know it's a tumor, definitely the grade can be defined by the amount of neogenesis. Like the two examples you see, what Gaurav has shown you. One patient, when everybody said that it is nothing, no tumor, it is just a radiation changes. And we said definitely the focus of high-grade glioma is there, which they did not agree. And the patient's relative, the husband came to me after a year saying, I'm sorry, we didn't accept you. And now it's all over the place. So what we're trying to say is the technique is looks pretty decent. And we have done like more than 2,000 brain tumors with Dr. Patir and Dr. Sunita and our group. And we are pretty happy. We published a number of papers, more than 50 papers on the technique and its application so far in all the leading journals of the technology. And I feel it's a very useful technique, to answer this. Yeah.
Dr. Gupta, can I ask a question here? Although we find that perfusion really helps in grading the tumor as well as in identifying whether it is a radiation-induced change versus a tumor, is one MRI perfusion enough, or do you often need to compare two sequential MRI perfusion scans to come to a?
No, if the values are very high, then we don't bother what perfusion. Even the first time I will say that. If the value initially is low and then going, like I gave you an example of patient, with the first patient, even the second patient, there was a focus of high grade. In my report, I write a grade 2 or grade 3 disease, because there is a very high area which is showing you something like 3, 2.9. And Sunita and me, if we keep fighting on it, they definitely grade 3 is also there. And then they try to find out where the grade 3. Indeed, Rana gives them the enough material to take that. And actually, we do a immediate post of every patient to know whether he removed that part or not. And sometimes I tell Dr. Patil that remove this, it doesn't remove it. He said, I'm sorry, I couldn't remove that part. So we know that where we are. I mean, we are reaching at that level. So I think we are pretty okay with that, actually. Yeah.
So, but then if it is a previously radiated tumor, then there is always a heterogeneity. There will be some amount of recurrence, there will be some amount of necrosis. Yeah. So in that, it becomes a little difficult, isn't it?
No, I have an answer to this. I keep hearing this from the radiation oncologists. And they keep telling me that how many cells are there, how many millimeter of cells are there. The question is, if you look at there is definite necrosis, Yeah. Even if what you call as a pseudo progression, even that has tumor cells, right? There are a number of papers coming into this. And we always have shown with a patient who has received radiation, Nana has operated a number of patients with the radiation changes, but there are tumor cells. If the tumor cell number looks pretty decent, I call it a definite recurrence. Okay. If there is a very tiny cells groups is there, then I call it predominant necrosis, but tumor cells are there. That's how I define these things. Yeah.
One more thing, like for calling it radiation necrosis, for what duration do you generally see the radiation necrosis happening? Like, is there a time limit after which you generally stop seeing the radiation necrosis changes in a patient who has been previously radiated?
The problem is radiation oncologists will understand that radiation necrosis continues to go. And early delay 2 years, below that 2 years, in all standard radiation biology stories are there. Yeah. So I don't think it's a process which stops. Because yeah, sure.
So if you are giving fractionated radiation therapy, say a patient is getting radiation therapy for a glioma, 54 to 60 grade, then the median time for a pseudo progression to happen is around 3 to 4 months. But if SRS has been done, say for a brain metastasis, then the median time for radiation necrosis is 12 months. So it varies from the fractionation and the total dose also.
No, I agree with you. The another question which we keep talking about, we had recently a patient who was diagnosed by whole NCR, there's definitely a recurrence in metastasis. And Dr. Patil was so confident, still he said, okay, let us do a perfusion, I'll go in the theater and operate. And when he was operating, he said, what Dr. Gupta said. And the boy wrote the report, it says, is a predominant radiation change, induced changes. Then he said, oh my God, I didn't see his report. So Sunita confirmed that. I told Sunita, you just do the staining for the tumor cells also. It was, I think, lung cancer with metastasis. And I said, look at the markers of lung cancer also. None of the area showed any tumor cells actually inside. So what I'm saying is, and Rana was happy, at least whatever I was saying is correct. At least he proved me right. Actually. That's what
Dr. Patil is there. Let's confirm.
Yes. Dr. Rana, So all this new information that we provide you, all these molecular markers and the radiology helping you in advance defining whether it is low grade or high grade, how does this information help you in decision making? Dr. Rana?
Well, for a surgeon, fortunately, our goals are very simple. It hasn't changed over decades, which is to try to remove whatever it is as completely as safely as possible. I think that guideline hasn't changed, whether it's a high-grade tumor, low-grade tumor. It hasn't changed 10 years ago. It hasn't changed now. That is our goal. So whether high-grade or low-grade, I don't think our surgical strategy changes.
So all this molecular information that we are providing you and really struggling to provide you with this kind of diagnostic facility. So how does it affect you ultimately?
So that's what I'm saying. I mean, that comes after I removed it.
Yeah.
So the decision,
Yeah. So
no,
it
the decisions, yes, of course it has relevance. It's important to pursue this because we start understanding more about the disease, and we are able to predict what the course might be in future. We are able to some extent, design the treatment in such patients. But the treatment is largely in terms of radiation, chemotherapy, and so on, since the surgical bit is over now.
So Abhishek, all these new entities, new markers, and all the NGS giving you targets. So how does it really help in gliomas particularly?
Like if we're talking about GBM, ma'am, so like patients who are elderly, like more than 70 years of age, I know that they are not probably going to be able to tolerate the concurrent temozolomide along with radiation. There, if you're doing this MGMT promoter hypermethylation, we have data now to suggest that if the patient is MGMT hypermethylated, probably he can forego the radiation and he can just receive temozolomide and he'll do very well as compared to giving just RT alone. Similarly, for like you're saying, this is TERT mutation. As Rana sir rightly said, that once the tumor has been removed, it tells us about the course of the disease, the biology of the disease. Like Dr. Gaurav presented that all TERT mutation is not going to be the same. Like if there is a subset of this oligodendroglioma, which is triple positive, these patients continue to live for years together. And they probably have the best prognosis. But while similarly, if we see it in cases of GBM, where it is IDH wild type, these patients tend to do the poorest. And similarly, for in the recurrent setting, again, if we have data for this MGMT methylation status available, that will tell us whether patient is going to have resistance to this nitrosoureas or your temozolomide again. And there is some upcoming, since we are talking about TERT mutation, there is some upcoming data that one of the drugs that we use to treat triple negative breast cancer, eribulin, it has shown some activity in patients of glioblastoma who are TERT mutation positive, particularly in the cell lines. And there are newer telomerase inhibitors that are being developed. In fact, one of them is used in treatment of myelofibrosis, ma'am. It is imetelstat that is there. That has also been tried in CNS tumors, but unfortunately, it is associated with some intracranial hemorrhage as well. So the trials are underway. But yeah, this molecular pathways, they will help us define targets. We've seen the success of BRAF inhibitor therapy in relapsed grade 1 gliomas. And we have seen the usage of these alkylating agents based on the methylation status. So yes, a lot of exciting things are happening, ma'am. And definitely it has helped us to redefine the classification of gliomas in a better way.
So Dr. Vinita, if like in the first case, if we had known about her molecular profile, could we have prevented the recurrence by some means? How this molecular if we knew the molecular information on her tumor, so how it would have. Dr. Vinita.
And the treatment for all gliomas, grade 2, grade 3, grade 4, it is now almost on a similar line. Earlier, we were using radiation therapy and temozolomide only for glioblastoma, which was grade 4. But now the new evidence says that even grade 2, grade 3 also benefit with concurrent as well as adjuvant temozolomide. So the newer molecular information just helps us prognosticate the patient and just helps us reinforce our belief that this patient is probably going to do better on temozolomide. As of today, I would say that we are not making any major change in the treatment. However, if the patient has a 1p19q co-deletion present in the tumor, then sometimes we consider this option of giving adjuvant PCV-based chemotherapy over temozolomide. Although majority radiation oncologists and medical oncologists are wary of the side effects of PCV and still stick to temozolomide in spite of lack of clear evidence in favor of temozolomide. So I would say that, as of today, it only helps me prognosticate my patients better. I know that, okay, this patient I'm going to see for a couple of years, coming back to me, he or she is likely to do better, but no major changes in the treatment. And can I ask you one question? Are you doing TERT promoter mutation regularly at your lab? Is it
Yes. So that is what I was going to say in conclusion, that in SRL.
Can I add something, ma'am?
Yeah, sure.
Very interesting discussion, ma'am. But I think clearly, and you all witnessed this, the GBM world has changed more in the last 5 years than in the 20 years before that. And I think what we are certainly seeing in the West, every ASCO, every Astro, we are seeing now discussions happening about the role of all these molecular diagnosis in therapy, in therapeutics. We are seeing which are the patients to pick up for vaccination, for example, which are the patients to pick up for targeted therapy. And the entire classification of who will benefit starts from your IDH1 mutant, MGMT methylation, and TERT and ATREX. So I do think that we are slightly ahead of the curve, but we are very proud to be there. So I think we will go back in time in 2, 3, 4 years' time. We will be, as therapies start in 5 years' time, we'll be ahead of the curve in that respect. So, and you know more than I do that it is a very a slow learning curve on all these. So it's taken you many years to develop this. So I think it's actually very good that we are possibly the only center which is doing it at that level, and that's a good thing. But as of use is not the point right now. The point is this is going to very rapidly be of use in the next few months. So IDH mutant treatment is going to be available in India most likely by end of 2.5, 3 years anyway. So we will start seeing some changes. Sorry for interrupting.
Dr. Gupta, are you able to see the scan? Dr. Gupta, are you able to see the scans and predict that this patient is likely to have IDH mutation? Do you have some means of predicting it on basis on?
He does tell us. He does tell us, and he does challenge us when we say it is not. And yes, and he's pretty often right than wrong. Just to conclude, I think we have overshot our time. More than the adult gliomas, I think this molecular profiling in young adults and adolescents and children is going to revolutionize the therapy. I really hope so, because at this moment we hardly have anything to offer them. And so I feel that NGS is going to be the thing to do for all these gliomas. But until it is affordable and available, we at SRL have a full panel of doing the molecular profile for both IDH positive and IDH wild type gliomas. So I thank you all, Dr. Vinita, Dr. Abhishek, Dr. Gupta, and Dr. Rana, for taking out time to participate in this panel discussion. This is enlightening. Thank you.
Very
Thank you,
right.
Gaurav.
Thank you, madam. I think it was very
Very
interesting, and we are, I think we are just discovering what all pathology can offer to us. And I'm sure that with more times and more tests coming, it will become more and more interesting to see what we can discover. Thank you so much, madam. It was a very interesting panel.
I just want to make one point that
Yes.
all the oncologists and all pathologists now should make it a point to freeze a bit of tumor, because we don't know in the next 5 years what is going to come up and how we can, we don't want to regret that, oh, we don't have frozen tissue for this tumor and we can't run this test and then help the patient. So I think it should become a policy that a bit of tumor, not much, 4 or 5 millimeter of tumor could be frozen or wherever possible. Thank you.
I would like to add one point to this.
Yes, Dr. Gaurav.
Biobanking is the answer to this, and this should be strongly recommended because in fact in our hospital we are very privileged to get so much amount of tumor tissue, almost gross total excision is so extensive that we are never in very few cases we are short of tumor. In majority of cases we get a lot of tumor tissue, and we must preserve that precious tumor tissue for future tests, for future upcoming monitoring. So biobanking is the answer, and we should start doing something to start this biobanking procedure in big cities.
So he was talking about biobanking. Biobanking is what he was talking about, right? So I think this is a discussion that we should have with our pathologists wherever we are. That how can we move ahead with this? And thank you, madam, for getting that bit of pathology amongst our oncology. But we are nothing without you, and we always look up to you. Dr. Rana may need you after surgery, but most of the times we need you before surgery, and then again after surgery, and then again after recurrence. So you are an inseparable part of oncology for us. Thank you so much, madam. Thank you so much in your panel. Thank you.
Thank you.
So with this, we conclude today's session at the Oncology ETC, which is the 4th annual conference of Oncology Forum. I think we had an exhaustive session. I must congratulate all those speakers who did the year in a nutshell. It was a tremendous exercise. I would try to get all those papers, in a PDF format and put it on the group, because they have gone through a lot of effort to create those PPTs. And I feel that all of us should be reading it. One of the faculties actually thanked me that because of which they had to look into so many publications throughout the year. So that is another thing that we look into. But I hope to see all of you and more of you tomorrow. Again at 4 o'clock at the 2 halls. We will have the same distribution of specialty amongst Hall A, Hall B. Tomorrow it is going to get a little hotter, a little spicier, because we have only debates and only debates. So I'm very sure we are going to overshoot the time again, because once it gets hot, you cannot control the emotions. And I hope this is the way we want it. And we'll see you tomorrow. And a last message that we will be having the 3rd day as a live physical session at Radisson Hotel Sector 18 at Noida, which will be transmitted live on the platform. But we hope it's a good sunny day. We have tried to get some arrangements done in the open as well. We have panel discussions in radiation, medical, surgical, and nuclear medicine. We hope to see many of you there and catch up on some old times. So good night and see you tomorrow. Thank you so much. Signing off from Fortis Cancer Institute. Good night.